1, and I'm going to give it a couple of seconds and it will be live.
Hi, thank you for joining us for the Multiple Sclerosis 2021 at the Frontier and Beyond virtual conference. I'm Dawn, and I'll just go through a couple housekeeping things before we get started. Next slide. So first, I just wanted to talk about the agenda really quick. As many of you already know, the program starts at 9. Dr. Yadoff will be doing a welcome. We'll go into Dr. Spain's talk on disease-modifying therapies, and then COVID-19 by Dr. Evans. Then we'll have a break with some virtual exhibits. We'll go into Dr. Pierce's cognition and healthy brain aging, and Dr. Yadoff's research from the Hill, and then we'll have another break at 12:05, and then we'll conclude with the Q&A panel. And so I'll go over that on the next slide here. So when asking if you have a question while a speaker is having their presentation and a question comes up, you can email me, Dawn, at chrisdaw@ohsu.edu. And if it's for a particular speaker, if you just want to note in which speaker it is and what your question is, that would be great. And at 12:20 p.m., we will be doing the live Q&A panel with the speakers to get your questions answered. Next slide. And this year, we're going to have the following virtual exhibits. So I just wanted to thank them for their support and involvement in this year's conference. We have Biogen, Genentech, and Novartis. So please take time at the breaks to stop by the virtual exhibits, and there will be links provided in the YouTube description you may have already seen, and the exhibitor email that you received yesterday. Next slide, please. This year, it's kind of exciting. We have a new way of making the conference even funner by doing a drawing. So if you visit an exhibitor, you can be entered for a drawing to win an iPad, earbuds, or a mug. And so visit a virtual exhibitor. They will have a passcode written or provided in their virtual space. And after the conference ends, then email me the passcode or the code words. And if you want to go ahead and put drawing in the subject line, that would be great. And then your name will be entered into the drawing. So I hope you guys have fun. And go ahead and do the next slide, please. And so without further ado, I'm going to go ahead and introduce our director of the OHSU MS Center, the professor of neurology at OHSU. She's also the director of the fellowship program in MS and neuroimmunology at OHSU and the Portland VA healthcare system, and a staff neurologist at the VA as well. She has research funded by NIH, Department of Veterans Affairs, PCORI, and National MS Society, and her interests are in novel therapies, complementary treatment options for MS, including dietary and lifestyle changes, vascular risk factors, antioxidants such as lipoic acid and MitoQ, and stem cell transplant. Please welcome Dr. Vijay Sri Yadoff.
Thank you, Dawn. Thank you for putting this program together. Really appreciate your hard work for all these several weeks now, in putting this program on a Saturday morning. And welcome to everybody from Portland here. I know there are many of you who are attending the program across the nation, maybe from other parts of the world as well. So this is the first time we have really extended this program beyond, beyond the US. So I'm hoping that this will be extremely valuable for everybody's education. And welcome again. Next slide, please. So I want to just, those of you who do not know who we are, I just want to give a brief introduction about who we are at the OHSU MS Center. We believe we are a leader in multiple sclerosis care and research. Next slide, please. OHSU MS Center was founded in 1983 by Dr. Dennis Burdett, who, along with Dr. Ruth Whittam and Dr. Michelle Mass, ran the center for the last 30 plus years, and has grown the center from few folks to basically following more than 1,500 people annually in our clinics. We have very strong affiliation with the Department of Veteran Affairs, Portland VA Medical Center. We are also proud to be member of consortium of the MS centers, as well as another foundation called Race to Raise MS, which basically is a center without walls and is a network of nation's top MS institutions that include Harvard, UC San Francisco, Yale, University of Southern California, UCLA, and Johns Hopkins. And we are also proud to be partners with the National MS Society, and we are a Center for Comprehensive MS Care here in Portland. Next slide, please. A little bit about the VA MS Center of Excellence is many of the attendees today could be veterans, and welcome to this program. MS Center of Excellence has been funded by the Department of Veterans Affairs under the DoD, and basically provides many avenues to the care for MS in veterans. Foremost is the clinical care, and these are clinical services for MS patients or veterans with MS, where they have access to this entire veteran health system, and then they can have a very strong network of integrated healthcare services. The VA Center of Excellence is also leading actually the center in education and training, especially for the VA healthcare providers as well as the veterans and their caregivers. The MSCO is also big on using the informatics and telemedicine technology to enhance the MS healthcare delivery, and also very big on research and development, where our own providers, clinical providers as well as basic scientists are doing real-time research both in clinical and basic sciences. Next. National MS Society, as many of you know, we have been partners with them for a very long time, and it provides a critical need for our patients, where many of the things that we are unable to provide in the clinics, the National MS Society comes and offers support. For example, the services that they offer, that includes the MS Navigator system, where they have the support almost one-on-one to the individual MS patient, and many things that patients struggle with, whether it is applying for disability or looking for resources of all kinds, that can be gotten through the MS Navigator support. There are self-help groups through the National MS Society. There are advocacy issues that National MS Society works very strongly on, and of course, the research support that is given by the National MS Society, as well as training the next generation of MS doctors. That's another big thing that the National MS Society has been really strongly supportive, and we are proud to say that we are funded by the National MS Society, not only for the basic science research, the clinical research, but also for training the next generation of MS doctors through this institutional clinician training award. Next. And more about our MS Center at OHSU, what we do. So as you know, we have providers, we have neurologists who are all fellowship trained. We have more than 8 doctors, 8 neurologists who provide routine care, ongoing care to patients. And in addition to that, because of the multidisciplinary nature of the MS care, we work very closely with many of the expertise at OHSU. Foremost would be, for example, infusion therapies. Like, as many of you know, the disease-modifying therapy, especially in the last 10 years, have shifted from injections to infusion to oral therapies, and the infusions are a big part of the MS treatment armamentarium. And so we have infusion services available as part of the MS Center. We have ophthalmology for eye issues, which many of you know can be a big problem. So we have neuro-ophthalmologists, which is an ophthalmology or a neurologist who's trained specifically in the eye diseases that affect our MS patients. We have for better diagnosis, we have really like an outstanding neuroradiology group who actually helps in diagnosing and helping with challenging cases with the right diagnosis, where, as you know, can be a huge challenge in some cases. We work very closely with the rehabilitation services, like we have access to the physical therapy, the occupational therapy, the speech therapy, the cognitive rehab therapy. All of those services are available at OHSU, as well as, like, you know, we refer patients to the local resources that they may have. March Wellness is a program based at OHSU and the waterfront area, where it's a unit which not only offers personal training, but has all ways to enhance the lifestyle if a patient desires, and that some of it could be covered by the insurances. So that's a very useful resource that patients should be reaching out to. Pain can also be a big problem in our patients, and we have a complete, comprehensive pain clinic at OHSU, and so they help with many of the complex cases that we see with pain. We also partner with the neurosurgery team for many of the difficult pain cases, or if there are cases where the spasticity, for example, is a very significant or can be a significant problem. So putting a backup pump or managing the spasticity using surgical technology or surgical methods can also be offered or can be done here very easily. We also take pride in having the neuropsychology as well as the psychiatric services available through the OHSU as well as sleep specialists. We work with rheumatology for cases which are somewhat complex, and if there are needs for, like, for example, fibromyalgia or joint pain, arthritis, all those issues which can affect many people are also available through the center. So I think we work very closely, and it's great to have this great partnership with many of our colleagues at OHSU, which allows us to really offer excellent service at OHSU. Next slide, please. So talking about our providers, very proud to have an excellent team of doctors working with us. We have 8 providers at OHSU who routinely see MS patients. And many of you probably know or recognize these doctors. So Dr. Kim, Dr. Bernard, Dr. Williscroft, Dr. Silverman, Dr. Lane, Dr. Spain. All of them have been, like, part of OHSU for a long time. Dr. Williscroft and Silverman joined us last year after they finished their fellowship with us last year. And Mary Fitzpatrick has been, she's a nurse practitioner who's been with us for the last 2 years. And Dr. Bodek, as you know, he retired from the seeing patients last year, but has been guiding the center and the fellowship program in a big way, despite not seeing the patient himself. Next. We also take pride in training the next generation of doctors. So we have currently 4 excellent fellows, and they're all neurologists who are training or who have finished or approaching finishing training in MS and neuroimmunology. Dr. Rice, she will be completing 3 years of fellowship here, and she'll be staying in town. Dr. Holland is doing his 3rd year of fellowship and really working on excellent research, very novel research strategies. Dr. Simpkins is a DO PhD who will be moving to San Diego, and Dr. Zhang, who's a pediatric neurologist, and we are very proud to have first pediatric neurology person who's actually getting training at our center and has done an excellent job of getting trained, and she will be moving to Tulane to do her, to basically join as faculty at the university there. Next. And this program, I think I should dedicate to our beloved nurse, Debbie Guess. Debbie, and many of you know, has been with the center long before I joined the center. So Debbie has been with us, I think, since 1996-97. She took retirement last year, but absolutely, she has been a star. She has been the one who has been pushing us to do the excellent work all along and has been holding our hand at so many steps, whether they are the doctors or the trainees or the patients or, like, trying to put things together. So I think I would really say that this program, I would really say will be dedicated to her service and her very well-deserved retirement. And I wish her the best always. Next. The current staff that we have right now, again, very happy to have them. Annie Chen is a PharmD pharmacist. She is an extremely valuable resource for us for any complex issues that come up in our patient care, especially with medications or infusions. And she's right there helping not only the doctors, but also the patients and holding hand, like, to help with the transition. Christine Perry is our backbone, and Nicole Aschenberg, she's LP, and she just joined and has been an outstanding addition to the center. Our research staff, who's again outstanding, I would say, and nothing short of those words, and all of them, they work so hard to help push the project like that we do, the clinical research that we do at the MS Center. Our fellowship program would not be functioning as well without the help of our stellar coordinator, Jamie Henry, and of course, education efforts won't be as good until Dawn would help. So I think kudos to you, Dawn, and thank you for your support. Next. As I said, education is a big piece besides clinical care for us. We take pride in doing the provider education program as well as the patient education program like this one that we are doing today. Until last year, we were able to do more programs. Like on the horizon was a program where we would be traveling, like before COVID, we would be traveling to different cities in the state, in Oregon, and those were hugely popular. And there was another program that we were doing routinely until COVID hit, which was Brown Bag. And that's where we would have pretty much either once a month or once in 2 month program where we would have people come to us. And I hope that we can bring that program or these program back once life becomes a little bit more normal. So I think I would definitely thank our support sponsors, who support these programs. And because of them, we are able to do these programs. The MS Fellowship Program, I'm very proud. We are very fortunate to actually have funding from the Department of Veteran Affairs for this education, plus the National Society, who's actually funding the fellowship program as well. We have conducted many what we call the continuing medical education or CME programs for the providers. So mostly they're neurologists, but like therapists of all kinds or other providers as well. And the examples have included the MS Wellness Research Symposium, where we have brought experts in the field of wellness, whether they are experts in diet or experts in exercise, expert in mental health, all of these things. And this program has been going on since 2015. The MS and CNS Neuroimmunology Symposium is also directed more towards the providers, but it has been going on for the last 3 years now. Today, this will be the 4th year for the program. And again, we bring experts from all around the country, all around the world actually would be joining us this year, where we discuss many complex cases, again, to enhance education of our providers. Next. The clinical research as it stands, and I'll talk more about that when I give the research update from the Hill, but the key people who are doing research, clinical research among the faculty are Dr. Burdett, myself, Dr. Spain, Dr. Woolscroft, Dr. Silverman, Dr. Cameron, and Cinda Hughes. Next. And basic science research at OHSU has been thriving under the leadership of Dr. Burdett. He has been sort of a bridge between the different aspects we have. And again, I'll talk much more about this in my presentation at the end. But we have excellent basic scientists, and what we do, whether looking for a virus which could potentially cause MS, or from learning about how myelin is formed and how it can be improved upon, like the after damage, or looking at different types of cells which could be helping in promoting the regeneration. All of those things is what OHSU takes pride in, and we'll learn more about that towards the end of the slide. So next. So in short, our mission is to help people with MS lead the best possible quality of life. And we provide comprehensive patient care services, community and physician education opportunities, and we strive to be a world leader in research in our quest to find cure for MS. So with that, I would like to wrap up my presentation and would like to welcome you all again. Next slide, please. And I think I'm extremely, extremely happy to invite our first speaker, Dr. Rebecca Spain. Next slide, please. So Dr. Spain is an associate professor of neurology at OHSU. She serves as the MS Clinic Director at the Portland VA Healthcare System. She's also an associate director of clinical affairs at the MS Center of Excellence West. She did her medical schooling from the Case Western Reserve University and did her residency and MS fellowship at Thomas Jefferson University. Her research interests include looking at new MS clinical outcome measures and working on role of antioxidants in MS, such as lipoic acid. So with that, I would like to invite her, Dr. Spain. Please welcome.
Thank you very much for having me. I'm going to share my screen. And And can I get a confirmation that my first slide is showing?
Yes.
Okay, super. Well, thank you so much, Vijay, for inviting me to speak today. I love this conference. And part of what I normally love about it is seeing all the faces out in the audience. So I'm imagining all of you participating on your screens from your homes, possibly out in many states and even out of the country. And so welcome and thank you for being here. So I looked back through my previous presentations and realized I had done a presentation for On the Horizon on DMT updates, disease modifying therapy updates in 2011, so 10 years ago. And looking through those slides really made me realize how much our thinking about who we treat and how we treat MS has shifted over the years. And so I titled this talk the Rethink episode. So I want to walk you through some of the ways our thinking has shifted in terms of disease modifying therapies. My disclosures, I do receive research grant support from the VA, National MS Society, MS Society of Canada, and OHSU, and there's some foundation support as well that is great, very helpful from the Fosters, and I do receive some consulting fees. So starting with, okay. So what am I going to talk about today? So first of all, we have had a shift in how we think about MS subtypes. I'll talk about rethinking the therapeutic approach, which has shifted along with how we think about subtypes. Rethinking the DMT landscape. I'm going to highlight 3 classes of disease-modifying therapies. So already I've given away that we've shifted from thinking about individual therapies to classes of therapies, groups of therapies. And then because we are grouping them together, we can rethink disease-modifying therapy development. So starting with subtypes. So this is kind of the old way. This is adapted from one of my 2011 slides. We said, here's relapsing remitting MS, where, can I just get confirmation that my laser pointer shows up?
Yes.
Okay, super, thanks. So, here's the picture we usually use for relapsing remitting MS. This is clinical disability going up along the y-axis, and these orange bars are when somebody has a clinical relapse. And after a relapse, a person has regains full abilities or maybe accumulates some disability, but is pretty stable until the next relapse. And relapses are normally accompanied by these purple arrows, which are new MRI lesions, enhancing MRI lesions. So here's a relapse with an enhancing lesion. And about 85% of people have this type of MS from onset. Then after a period of time, people with relapsing disease transition to secondary progressive MS. And so at this point, instead of being stable between relapses, there's an slow accumulation of disability until the next relapse, and then ultimately really no further clinical relapses, but there can be gradual worsening. So we call that secondary progressive MS. And classically, we've been saying about half of people who are diagnosed with relapsing disease will reach the secondary progressive form of MS about 10 years after diagnosis. Then we have this clinical phenotype, primary progressive MS, which looks a lot like secondary progressive MS, but it's that way from the beginning of disease. So some slow worsening, maybe some periods of stability, maybe actually even a clinical relapse sort of superimposed on it. And there are fewer MRI changes. And then we had this kind of confusing category that about 5% of people had, which was this progressive relapsing, which was kind of a mix of many clinical relapses, but also clinical worsening. All right, so that was the old way. What's changed? So the new way, nothing's really changed about the relapsing remitting phenotype. But excitingly, with secondary progressive MS, instead of that 10 years, it's now 20 years. So we're saying that after diagnosis, it now takes 20 years for half of people to reach this secondary progressive phase. And that is really exciting. And that is really due, we think, to our success at treating relapsing disease early in the course. So we have doubled the, we have delayed the disability of secondary progressive MS by 10 years, doubled that length of time. So that's been a great success. Primary progressive MS still looks the same, but we pretty much eliminated this progressive relapsing course. It was confusing and not very helpful when it came to treatment. I'll also mention clinically isolated syndrome. So that is the first clinical attack that somebody has where they experience disability. There have been an update to our diagnostic criteria so that now we are able to diagnose relapsing remitting MS often at the very first attack. We don't have to wait for the second attack and miss an opportunity to treat MS. So that's been an update. And I'll also mention this radiologically isolated syndrome. That's one of, can you see this purple arrow here? That happens in somebody who doesn't have any clinical disability at all. Maybe somebody was in a car accident or had a migraine and got an MRI of their brain, and it shows a lesion that looks just like MS, but they don't have MS yet. So right now, that's an area of research that maybe Dr. Yadav will talk about whether or not we start treating people with this radiologically isolated syndrome or not yet. So now that we've kind of reduced the number of categories we have, we can now use some new terminology when it comes to looking at the types of MS. So instead of these strict categories of clinically isolated syndrome, relapsing remitting, SPMS, PPMS, and you might have been like one of the many people who come to me and say, well, I don't get it. Which kind of MS do I have? And it's not often an easy discussion. So now we have shifted to using the terms relapsing forms of MS. And we modify that saying with or without activity, meaning with or without a clinical attack or MRI lesions. So a relapsing form of MS. So this includes our clinically isolated, our relapsing remitting, and even some of our secondary progressive MS people who are accumulating some disability between relapses, but still have clinical relapses. So that's a relapsing form of MS. And here's a progressive form of MS. And again, with or without activity. And so what I mean by progressive form of MS, we're saying this includes some people with secondary progressive and people with primary progressive who are accumulating disability, like we expect, and with or without activity. And in this case, what we're really talking about is new MRI lesions. So we're talking relapsing forms and progressive forms. So instead of splitting, we're now lumping. And I'll tell you the advantages of doing it this way. So the FDA, for instance, now, the FDA label now uses relapsing forms when it approves medications for MS. So this can reduce some insurance barriers that says, oh, well, your chart says you have SPMS, but so we won't approve your MS therapy. But even if you have SPMS, if you have a relapsing form of it, there's still clinical relapses or new MRI lesions, this therapy will be approved for you. It also connects the treatment to the mechanism of disease, right? So pretty much all of our MS therapies are anti-inflammatory and they treat relapses. So they treat these relapsing forms. So that makes more sense than connecting a therapy to a type of MS. Really, it connects it more to the underlying process. And then it also encourages us to then think about, well, what are we not treating? and it encourages research to develop treatments for the progressive mechanisms of disease. And these can be neuroprotective, remyelinating, regenerating, and so I'll let Dr. Yata talk about those later on. There are still some questions. For instance, should we be treating stable relapsing MS? So what about these people here? You know, maybe this is several decades. Do they need treatment when they're in this stable period? Should we be treating non-active progressive MS? So how about even if, well, let's see, this would include the time, maybe the green and the blue periods of time where somebody has slow worsening or they're even stable, but they don't have clinical relapses that we know can be treated by our anti-inflammatory DMTs. So I will say that there's an ongoing study that Dr. Yadav may discuss about trying to answer those questions. So we don't want to overtreat, but we don't want to undertreat. Another question is, should we be treating secondary progressive and primary progressive MS the same? They kind of look a lot the same. Should we be treating them the same? And then a final question is, when do we stop treatment? And that's, again, a subject of another research study. Okay, so we've rethought the subtypes. Let's rethink the therapeutic approach. This has also changed in the last 10 years. And I think it was really kicked off by this study, or at least it was kicked off for me for this study. This is from 2010. And this study was drawn from the NARCOMS database, the North American Consortium, NARCOM. It's a North American survey that many of you may participate in, where people with MS send in questionnaires every 6 months with questions about their MS and their disability. And using this database, which is very large, I think over 6,000 or more people in this database, the researchers asked the question, if you had any vascular comorbidity or had no vascular comorbidity, how was there a difference in the time it took you to need a cane to walk? So I'll walk you through this slide. This means that if you had a vascular comorbidity, and I'll define that in a minute, any vascular comorbidity at 13 years, approximately half the people needed a cane to walk. But if there was no vascular comorbidity, the group of people who had no vascular comorbidity, half of them needed a cane to walk at 19 years. So, said another way, if people had one or more vascular comorbidity at MS diagnosis, at the time of diagnosis, they needed a cane 6 years earlier than those with no vascular comorbidity at diagnosis. Okay, so what do I mean by vascular comorbidity? For this study, they meant diabetes, high blood pressure, heart disease, high cholesterol, and peripheral vascular disease. Currently, we also include obesity and tobacco use as things that can affect small blood vessels. All right, well, gosh, if I could take a medication that would delay my needing to use a cane to walk for 6 years, what medication would that be? I'll take it. Well, I'll tell you what some of that medication can be. We're talking exercise. We're talking eating more fruits and vegetables, and we're talking stress reduction. And these things can treat these vascular comorbidities and can reduce disability in MS. So really, this was evidence that what we eat, how we exercise, how our lifestyle really has an impact on MS. So that shifted our therapeutic approach. In the old way, we said, all right, you must get on a DMT. That's the most important. Then we have to manage relapses. Okay, we have to treat the symptoms. And oh, yeah, don't forget, it's important to be healthy. What's our new way? Being healthy. Wellness and health maintenance is the #1 thing you have to do when you get diagnosed with MS. Disease-modifying therapies are still very important, and we know now it's important to get on them soon and get on the right one. Symptomatic treatments to help the day-to-day symptoms are important. be able to engage in the wellness and health maintenance activities that are important. And, you know, fortunately, with our improvement in efficacy of our disease-modifying therapies, we are actually doing much less relapse management. We see fewer people in the hospital for relapses. We're handling people relapses in the home, and I think we've made a lot of success in reducing relapses. So wellness and health maintenance is number one. Okay, some other shifts in our therapeutic approach. Now, we've always said, all right, a risk benefit when it comes to choosing an MS therapy, we've always looked at the risks versus the benefits. And we still do that. So we think, okay, what's the safest drug that I can take? But also, what's the most effective drug? And often the safest ones are not the most effective ones. And so it's a trade-off, and you have to weigh the need for safety and the need for efficacy, or how effective the therapy is, along with some other considerations like how route of administration. And we still think like this, but we've added some more layers of consideration. So I'll go through those layers of consideration. One of the layers is this disease status. So we have to think, how active is your disease? I mean, do you have rip-roaring MS with relapses every 6 months? Or did you have one relapse 10 years ago and nothing in between? Because that should nuance how you could be a nuance on how aggressive you want to be. So some people will argue that if you're starting out with a very seemingly, I would say benign MS, meaning that it was a mild relapse without much disability and you recovered quickly, you start on the safest medication. However, if you're starting your MS with a very disabling attack and there's slow recovery and there's another one quickly after that, you should start out with, even if it's riskier, a more aggressive therapy. I would say there's even another approach that says, which we call the induction paradigm, that says actually everybody should start out with a very, very effective medication and take it for a short period of time, teach that immune system a lesson, bring it down, make it quiet, and then after you take that very effective medication, you can take a safer, less effective, but you may not need that riskier medication after you've had a period of a very highly effective medication. So, and that would be even regardless of how aggressive the disease is. So that's called an induction paradigm. And there's a research study going on right now that hopefully we'll get some results in the next year or two even, that gives us some clue as whether we should be hitting MS hard with our most effective, even if they're the riskier medications, early for a better bang for your buck in the long term. So stay tuned on that one. Another nuance that we've been looking at more recently as well is the effective age on the DMT effect. So this is a very pretty slide. It's a little bit confusing actually to understand, but what the general gist is, when you're younger, 35s, 45s, 55s, under 50 even, and this is drawn from clinical trials of all of these therapies listed here on the right. So even though in real life we are treating people older than age 60, the clinical trials often included younger people. So the overall gist is that our MS therapies are more effective when they're given to younger people than they are when given to older people. That's not to say there isn't a role for our disease-modifying therapies in older people, but we have to think about, is it getting you as much benefit and is it worth that risk? So we have to add that component of age into our thinking. All right, so I just made that much more confusing, I think. It's not just a simple risk versus benefit. It's now risk, benefit, how aggressive is disease, what is your age, And do we want to try this induction approach, or do we want to try an escalation approach? So these are nuances that I think will help once we get some answers from our trials, help instead of a one-size-fits-all approach to giving therapies, narrow it down and individualize the therapies much more appropriately. Okay, so I want to now talk about rethinking the disease-modifying therapy landscape. I think all of you are probably very familiar with slides that look like this. I I graduated from medical school in '92 and did my fellowship until 2006. And so when I finished fellowship, there were really only injectable medications. Natalizumab had been off the market in a black box and then had just been reintroduced. There just weren't that many options. Look how many options we have now. We've had an explosion of therapies. And then you can also see the green ones are injectable ones. The oral ones are in blue, and the infusions are in red. And there's more being developed all the time. So how do we make sense of all of these new medications? I would say the old way of thinking about them is by the root. And if you look on the National MS Society website, this is kind of how they organize them. So this is where I took this slide. Here are the injectable ones, here are the oral ones, and here are the infused. There's other ways to think about them. You can think about the disease-modifying therapies by price. And this is work that Dr. Bourdette has done a lot in and really highlighted this issue to the field. These are the prices of MS therapies over the years. And even the same therapy, starting here with beta seron, has gone up and up and up and up. And now we're at therapy starting at $100,000 a year. So that's another way to look at therapies, but that's a whole other talk, and I'm not going to go into it. You can, so what I would say is we have so many therapies now, we can start grouping them into classes of drugs. And this is helpful because some of the new medications that come out are very similar to previously approved medications, but they have some slight modifications that maybe make them more tolerable or have a different route of administration. So they're not exactly me too medications, but they are in the sense that they are the same class of medications, meaning the same mechanism of action. And I find it helpful to think of it in terms of classes of drugs, and then I can understand whether is this kind of the same medicine with a twist, or is this something brand new that may attack the MS in a new way. So I've grouped them for you this way. Here are the interferons, which you are probably familiar with. Glitiramir also has a number of generics. We have fumarates, and those are our familiar dimethyl fumarate or Tecfidera, bafirtam, I'm sure I'm pronouncing that right, Vumerity, and then we're having some generics coming out recently. I know the VA just a couple of weeks ago, veterans taking Tecfidera now are receiving a generic dimethyl fumarate, which works the same. It's just really lowers the price, which is great. We have these S1PR modulators, S1P receptor modulators, and so that's our fingolimod, which is Gilenya, and then there are a few newer ones that are variations of these S1P receptor modulators, Mayzent, Zeposia, and Ponvory. I'll talk about these a little bit more. B-cell agents, so that's Ocrevus and Kesimpta. Now I could put rituximab on here. Rituximab is actually not FDA approved for MS. We use it frequently off-label. It's our go-to at the VA because it does work the same way as these other approved B-cell agents, but I only put the FDA approved ones on here. And then I have kind of a grab bag of others that have unique mechanisms of action. So Novantrone, Tysabri, Aubagio, Lemtrada, and Mavenclad. And I'm going to talk more about Mavenclad and Ocrevus just to give you some updates on those because they are new and have, I would say they have the newest mechanism of action in the last 5 years, let's say. So a little blow up with this. You can see how many new medications have come on the market in the last 5 years. Ocrelizumab, siponimod, cladribine, diroximel fumarate, ozanimod, ofatumumab, monomethyl fumarate, ponesimod, and intramuscular interferon beta-1a. I mean, it's just impossible to keep up on all of it. But the important thing is that we've only really had 2 agents that had a new mechanism of action in the last 5 years. And so those are the ones to pay attention to. So I'm going to highlight 3 classes of disease-modifying therapies that are important to go over. So I'll start with the B cell therapies. First of all, why are B cells so important to MS? B cells are important in a number of ways. What they can do, the B cell is shown here in blue. It is part of our innate immunity. It presents and it stimulates other parts of the immune system, so that the immune system can do the job we want it to do. But B cells can also stimulate the immune system to be reactive in an autoimmune way and cause autoimmune damage in MS. B cells are important as well as in that they produce antibodies, and in the case of MS, we are assuming they're producing autoantibodies that are attacking our own immune system. So what do B cell therapies do? We actually really should call them B cell depleting therapies. What B cell therapies do is they attach to a CD20 receptor, which is shown on, which is expressed on B cells during development. So our B cells start out their life in bone marrow as stem cells, and they become a pro-B cell, and then they develop into the teenage years. I call them a pre-B, a mature activated, a memory, and a plasmablast B cell. And then when they are fully mature, they become a plasma cell, either short-lived or long-lived. Well, during their development, they express different receptors. And the CD receptor is expressed during what I call the teenage years of B cell development. And so our B cell therapies attach to this CD receptor on these developing B cells. And those cells are eliminated from the body, they're depleted from the body. And what's remaining in the body are stem cells, which will again try to grow up into adult plasma cells. But it's important that what does remain in the body are all the long-lived plasma cells that remember the infections we've had in the past, remember our vaccines that we've had in the past, so that we stay immune to chickenpox and polio and those type of things. So B cell depleting therapies remove B cells. Not all of them, but a lot of them. There's different kinds of, there's some different flavors of B cell depleting therapies, and their flavors come in how they're manufactured and what exact portion of the CD20 receptor they attach to. And so whether you're a lumper or a splitter, you can call them all the same, or you can call them 3 distinct things. The FDA is happy to call them distinct things and give them each their own patent. So, but they all end up depleting, even if they do it in slightly different ways, these developing B cells. I thought this was kind of funny. All right, mice, you time to be men. So, and one of that cartoon refers to the fact that the newer B cell depleting agents are more humanized, more like human antibodies and less like mouse antibodies. So speaking more about specific B cell therapies, how they work, depleting B cells is similar. So what are the differences between them? And I'll talk about ocrelizumab, which is Ocrevus, and ofatumumab, which is Kesimpta. So the main difference is ocrelizumab has an indication for primary progressive MS based on studies in that population, whereas ofatumumab only has an indication for relapsing forms of MS, that's CIS, RRMS, and active SPMS. Another important difference is that while ocrelizumab is an infusion, ofatumumab is a subcutaneous injection once a month. And that can be a real advantage for people who live far away from an infusion site or potentially travel parts of the year or have other reasons not to come in for a once every 6 month infusion, but would rather have a self-inject a subcutaneous injection. Obviously, people who've had problems with subcutaneous injections before would probably prefer an every 6 month infusion. And another important part is how long it takes for those new stem cells to grow into mature B cells again. So if you stop ocrelizumab, it can take 72 weeks or more to recover your B cells. Basically, it's a really long washout period. That washout period is cut in about a half with ofatumumab. So I will also highlight Mavenclad, since that's also a new mechanism of action to our landscape. So cladribine was approved in 2019. Again, it's relapsing forms of MS. It's an interesting medication because it's been used to treat leukemia and lymphoma. So actually, we have a lot of safety information from how it was used in the leukemia and lymphoma populations. What's nice is it's very effective as an oral medication. And it has a very unique dosing strategy. Basically, you get it, and I'll walk you through this. So the first treatment is 4 to 5 days of pills, depending on your weight. You wait 3 to 4 weeks and take another 4 to 5 days of pills. So that's the first treatment course. A year later, you repeat the treatment course, and then that's it. You don't ever get cladribine any further due to risk of long-term adverse event. So in a way, it's like a dose at year 1, a dose at year 2, and that's the end of dosing for cladribine. So very unique. So how does it work? It's a purine mimic, meaning it's a protein mimic that gets incorporated into the actual DNA of B and T cells. Those are some of our immune cells. And it leads to cell death in those cells. So it suppresses the immune system, not just B cells like our B cell depleters, but B and T cells. Some other highlights of cladribine. And I'll summarize it here. It's generally recommended for patients who've had an inadequate response to an alternate drug, and that is from a recommendation paper. So unless we're using the induction approach, generally if people are having breakthrough disease on another MS therapy, this would be when we would think about using this very effective agent, cladribine. Some of the risks include a low white blood count, infections, and possibly even malignancy. I'll just say a few words and not go through these slides in detail about these S1P receptor modulators. That's the fingolimod and family, just because so many of these similar medications have come out recently and more are likely to come out. So these medications work, they're an oral agent, by trapping white blood cells in the lymph nodes. So the lymph node system is shown here in this figure, and it kind of parallels the circulatory system. And these lymph nodes, blown up here, are where immune cells learn about foreign enemies and then go out and attack those foreign enemies. Well, the way these fingolimod and family medications work is they trap the lymph node, they trap the white blood cells in these lymph nodes, and then they're not available to go out and attack the immune system and cause relapses. So trapping them in the Roche Hotel, essentially. The difference between all these new S1P receptor medications is the type of receptor that they are able to attach to. And a lot of the side effects that come from these agents come from the fact that it binds receptors in parts of the body where we don't want it to have an effect. We just want it to have an effect on the white blood cells going into the lymph nodes. But if it affects the heart, you can have cardiac effects. If it affects the lungs, there can be problems with asthma. So the fewer receptors that are, or the more selective the agent is, the fewer side effects. And so some of these newer agents are more selective. How they treat MS is the same, but they have fewer side effects, which can be important. There's some other differences in terms of how quickly they wash out and whether or not you can take other medications or eat other foods with them. So there's a lot of detail to go through. And I'm going to wrap up with just a few slides on rethinking disease-modifying therapy development. So a lot of the current therapy development is optimizing current disease-modifying therapies so that they have fewer side effects. And this is an important thing to do because we want to take the risks out of these medications. We want them very effective with very few risks, right? And so optimizing existing disease-modifying therapies, they're sort of me too drugs, but they're important to do, is one approach. Targeting the immune system is something we're really good at. And in fact, all the therapies I've talked about and shown you really target the immune system. So we're really good at targeting the immune system, and more therapies are in development that are doing that. But what is new is exploring new mechanisms of action, new classes of drugs that are targeting part of the MS process that hasn't yet been well targeted by simply targeting the immune system. So for instance, targeting other aspects of MS, we want to repair the nervous system. So we want to remyelinate and rewrap those axons. We want to preserve the axons that are there. We call that neuroprotection. So we don't want those axons to, when they're demyelinated, be more vulnerable to aging processes. So we want to protect the existing axons. And we also want to provide indirect support. So remember that slide where I said exercise and eat vegetables and do stress reduction activities? You know, maybe we need to get even more aggressive at optimizing those lifestyle habits by really doubling down on treatment for high blood pressure, for diabetes. And so indirectly support treating MS and support healthy living with MS. And we also need to think about what are the measures of our treatment success. And so we're used to using this expanded disability status scale where somebody has no disability, they start having some walking restrictions, they start needing a cane, a wheelchair, and then are bedridden. And that's our standard outcome scale. But maybe we need to rethink that too. Like, what is really important? Is it walking that's important, or is it income? Maybe we should use people's ability to have earn a good income. Maybe we should think about how often are people visiting doctors as a as a way, or emergency rooms as a way to see whether or not a medication is a success. There's this quality adjusted life year that sometimes gets used. What about depression scales? What about quality of life scales? What about asking people with MS what they think is working or not working for them beyond just a disability level? So we also need to think about, what does it mean to have a treatment success? And that is starting to change how we design our research trials too. So this was our Rethink episode. I hope I provided some interesting new thoughts for you as well, and I look forward to the Q&A session. We thought about the subtypes, thinking more about relapsing forms and progressive forms rather than these strict categories. We thought about with or without activity. Is it stable? Are there relapses? Are there new MRI lesions? And does that mean you need to treat during times without activity? We rethought of the therapeutic approach, with health and well-being being the first thing we need to do, because it does change the disease process. And we need to consider if MS is aggressive or stable. Should we use induction therapy for everybody? Should we be aggressive very early at the beginning, teach the immune system a lesson, and then we can back off those therapies? Is age a factor? Rethinking the disease modifying therapy landscape by grouping into classes of drugs. And when a new drug comes out, we can think, is this a different or better version of an existing class drug, or is it a whole new class? And rethinking disease modifying therapy development. What are the goals of treatment? So I look forward to your questions at the end, and I am going to stop sharing and turn it back over to our presenters. Thank you again.
Thank you, Dr. Spain. Thanks, Dr. Spain, for that excellent overview of the disease-modifying therapy. And I hope that we will answer many of the questions that people may be having. I know many of the people had posted their questions on the YouTube. So we have taken those questions. Dawn has taken those questions, and we will be addressing them in the Q&A session. So, but I think the best way is to email the questions to Dawn so that we can try to address as many of them as best as we can. So thanks again, Dr. Spain. Very nice presentation. So with that, the next presentation, I'm extremely excited to listen again. And we've had Dr. Evans actually teach the doctors, when the COVID first hit. And I was so proud to be connected with him since. So it's been more than a year, actually, that we've been collaborating. So I'm very happy to have you and speak to our patients directly. And to talk about Dr. Evans. Dr. Evans is an assistant professor of medicine in the Division of General Internal Medicine and Geriatrics and Infectious Diseases. He did his medical school from Drexel University and then residency from Albert Einstein School of Medicine in Bronx, and then fellowship in infectious disease from there as well. He is an infectious disease and HIV expert, and since the COVID pandemic, he has been really on the forefront of guiding all of us, clinical care or research or different aspects of vaccine, for example. So I think I'm really excited to hear the latest now, where we are now that we are hopefully above the, or beyond the pandemic to some extent, and with the vaccinations, taking over, the mainstay of our disease prevention. I'm really curious to hear, what you have to teach our audience. So with that, please welcome Dr. Evans.
Thanks, Dr. Yadav. Thank you so much to the conference organizers for inviting me back to talk about a topic where I think when I started fellowship years ago, I don't think many infectious disease doctors knew that it would be in the midst of a 100-year-old sort of pandemic once in a lifetime. And so this really has shifted both resources as well as sort of our approach to both public health to kind of understand how much we need to sort of reinvest back in some of the systems that we have sort of neglected over time. So, so again, I am not a neurologist, but again, I really feel grateful to be invited back into this space to talk about something that I'm really passionate about. So without further ado, next slide, please. So, oh, next slide. Oh, perfect. So I have no disclosures. Next slide. So again, this has been sort of a once in a lifetime pandemic. I think, when I was in medical school, we always talked about the flu pandemic of 1918 and sort of how devastating that was for many populations, including here in the United States. This is sort of a slide that showed, what, pandemics looked like. And I think this is kind of the picture that people had. And I think in a sense of hubris, we thought this would probably never happen. If it did, we would have all the sort of amazing modern technologies to sort of fight this. And we do have much better technologies, but again, with over 500,000 people dead in the United States, and of course, millions around the world, and still the pandemic is raging in many countries, developed and undeveloped countries around the world. When I was a resident, I think I saw the movie Outbreak, and that's sort of what we thought of as where pandemics would look like. You had the Hollywood men in suits, and they'd come in and so forth, and it hasn't looked like this. This looks like our next door neighbors who've unfortunately gotten sick, and definitely we talk about folks living with MS who may have some very unique risks. We definitely need to kind of figure out how best to serve and how to protect this population. Next slide. So the objectives of this talk are going to be a couple of things, and I really have to thank Dr. Spain for setting me up with some of the immunology that we'll sort of talk about when we talk about the vaccines. I know that, when we talk about sort of the depletions of B cells and depletions of T cells, which are kind of our cornerstones of fighting infections, this definitely is going to have bearing on how we respond to infections as well as vaccines. So one is just kind of give everyone a quick overlay of the epidemiology, transmission, and clinical symptoms associated with COVID-19. Number two is to kind of discuss a little bit about what's known about the severity of COVID-19 in MS patients. Number three is discuss the various COVID-19 vaccines approved in the United States, highlight some of the efficacy of the vaccines as it specifically relates to MS patients. And then I think the most important thing is really to kind of highlight some of the recommendations around vaccines timing when someone's on a disease-modifying therapy. Next slide, please. So to kind of give you context about COVID or coronavirus 19, we have seen prior SARS infections in the past. There was a previous infection back in, I think it was the early 2000s. There was a big outbreak in Toronto. And then we had a lull. And, we know that COVID, coronavirus, SARS-2 is sort of a family of sort of common sort of cold viruses that we have seen. If you look at the bottom left-hand corner of the screen, you have the beta coronaviruses, and that's sort of where coronavirus comes from. And so we have seen these cold viruses, but what has been unique about SARS-2 is this pathogenicity as well as its infectiousness. And so, most people, when we get exposed to sort of these normal coronaviruses, we just have mild cold symptoms, we get better, and then that sort of resolves. Of course, we know that the name coronavirus comes from the very well-described spike protein that's on the surface of this virus that gives it sort of this corona halo, and hence the name COVID or coronavirus 19. All right, next slide, please. So one of the things that we always are concerned about with any sort of pathogen is how infectious it is. Pathogens that are highly infectious but have maybe highly lethal and don't have a long incubation period, they tend to sort of they typically don't spread very far, because if the host gets infected and dies quickly, it doesn't give much time for that host to then transmit that virus along to someone else. Typically, when you think about sort of transmittability of viruses, we think about it called an R naught. And say, to give you an example, the R naught of measles means that if one person gets measles, about 18 people, 12 to 18 people can get measles from that one infected individual. The R naught of SARS is kind of around, I think the average people would say is about 3. Here in the slide, it says between 2 and 5. And we do know there are probably specific situations where one person can actually infect more than 5 people, depending on the amount of virus they have and kind of how the environment is in terms of circulating air and fresh air and so forth. Another thing too we know is that when someone gets infected, the big blind spot that I think a lot of public health officials missed in the beginning was the fact that people who were asymptomatic, meaning they had no symptoms, but they had a lot of virus in their noses and in their respiratory droplets, were passing those infections along to someone else before they actually presented with symptoms. And so this continues to make coronavirus difficult to control without sort of public health measures such as social distancing and wearing masks, and now, of course, vaccines. But this whole idea that we have this asymptomatic period where you can transmit virus, again, has made more people sick before they know they were actually sick. Next slide. So we know that the virus doesn't last very, very long once someone's actually positive. We may have evidence of virus, but is it really viable virus? And so if we were to culture someone for respiratory droplets, we know that the virus probably doesn't remain viable after, say, 9 days of symptoms. We know that, of course, that, we talk about the 6 feet as being sort of the holy grail of transmittability. And I always take that with a grain of salt because, again, there may be situations where 6 feet may just not be enough. If you're in an environment where you have air being circulated, fans blowing, 6 feet may transmit those droplets much further. And so, again, there's nothing that is sacrosanct around 6 feet. We just think that the further you are away from someone, the less likely when someone speaks or coughs that virus-laden droplet is going to be able to travel. Again, those virus-labeled droplets, the heaviest ones will fall first and fall to the ground. The lightest ones will sort of float a little bit before they fall into the ground. And so the susceptible host, someone who's never seen COVID, will again inhale those. And of course, it goes into our respiratory tract, and then hence we cause illness. Next slide. So one of the things we know is that there is definitely still COVID circulating in our community. This was the slide that I just took from Multnomah County that showed about new cases in our state, actually around 370 new cases, and we're kind of averaging about 295 cases weekly. I could say here at OHSU, we're still seeing our wards with COVID patients. One of the things I just want to highlight about this is also that, the really difficult thing around really trying to limit not just COVID or symptomatic COVID patients coming into the hospital, but also the fact that think about all the other diseases that are sort of neglected. So people are still having, unfortunately, heart attacks. People are still having, infections after they have a surgery. And so where do those people go when your beds are full from people with respiratory COVID infections? And so we've really had an increase in our hospitalizations and or decrease in our beds. And so that's really making it more difficult. But the good thing, I think, is just to take from this slide is the decrease in sort of daily cases, that are daily cases, the positivity rate is actually decreasing. So if you sort of took all comers and sort of tested people, the amount of people testing positive daily is actually going down. So we think with more vaccines and hopefully more herd immunity, that this will go down even more. Next slide. So one of the things we know about COVID and COVID is that there is this spike protein. The coronavirus has this really critical spike protein, and this spike protein is actually the key ingredient to target humans, and actually is sort of what allows for this human viral interaction. We know that the sort of mutations in certain parts of the spike protein, specifically the RBD, the receptor binding domain of the virus, is actually one of those things that actually makes the virus actually change and mutate. So we think about, you might hear about variants or you might hear about mutations. It's actually changes in the spike protein of the virus that then may make it actually more efficient at attaching to cells, or again, just transmittability. Next slide, please. So what happens if someone is unfortunately go back. Previous slide. Thank you. So what happens if someone is exposed to coronavirus, to COVID? We know that, of course, the spike protein interacts with a very specific receptor that's found in human epithelial cells, so the cells that line our airways and our small airways called line our small airways. And those cells have really important receptors sitting on top of their surfaces. The ACE2 receptor is really critical, and there is an interaction between the spike protein on the coronavirus and, of course, this ACE2 receptor. Eventually, what happens is that the virus gains entry using this receptor and then undergoes viral replication in the cytoplasm, the cytosol of the cell. Of course, our bodies sort of recognize that, and of course, they launch this massive sort of, no holds barred immune campaign against the actual replicating virus. And so our bodies recognize antigens, which are basically foreign entities, and they activate your macrophages, they release cytokines. As Dr. Spain talked about, we have a sort of our priming of our immune system with our B cells and our T cells, sort of trying to fight this virus, and then, of course, produce antibodies to then attach to the virus to kind of clear the virus. And I think one of the things that really becomes an issue is that when we talk about maybe some of the disease-modifying agents that deplete many or certain aspects of the system, or may sort of dampen down some aspects of the system, whether or not they sort of, I like the term that Dr. Spain used, they sort of affect the sort of development of those teenage B cells. How does that then affect sort of our ability to kind of respond to ongoing infections? And so again, when we know that when the virus actually gets in and all of this sort of stuff gets activated, this causes a lot of inflammation. This inflammation, if you can think about in our small airways that are supposed to be pristine and need to sort of be open to exchange oxygen, now get filled with debris from all of these inflammation and so forth. And of course, that causes people more difficulty breathing. And of course, with that, then unfortunately, some people need to get respiratory support. And unfortunately, even despite having respiratory support, people will unfortunately pass away from this illness. A lot of this inflammation also leads to development of clots. One of the things that I think is really characteristic of COVID-19 is the fact that we see clots in all areas of the body. We see clots in the brain and the kidneys and the lungs. And of course, clotting off any sort of blood vessel then affects the ability of that organ to function normally. Next slide, please. So who are the people who are being affected by COVID? And one of the things we know that is probably there, especially when, I know I'm talking to an audience around MS, but there's probably an intersectionality among folks in terms of other groups that they may fit in. So, we know that being older is a big risk factor for mortality associated with COVID. We know that there may be people on this call who may have MS and also may have diabetes. We know that diabetes is a risk factor for poor outcomes. Heart disease, of course, is a predictor for poor outcome. And so if we look across the United States and around the world, race, especially here in the United States, being a Black race, of course, is unfortunately an important predictor of poor outcomes. outcomes. And again, this may have many overlying reasons to why this is happening, but we know people who have these characteristics have died at a much higher rate as compared to the general population that do not have these characteristics. Next slide, please. So this was actually a really good study. This actually just got published in the journal JAMA's Neurology this month. And this was a study published by Salter. And what the question came up to is when we look specifically at MS and people who have get COVID-19, how good or bad do they sort of fare as compared to sort of the general population? Do they have worse outcomes? And so basically the study looked at about 1,600 North American patients with MS and COVID-19, and they had various degrees of sort of states or subtypes of MS. But what they found was that the overall mortality was about 3.3%. And they found that about 74% of those people in that study had relapsing remitting MS. There were some independent predictors of mortality, and what they found is that if you had sort of an ambulatory disability, that independently increased your odds ratio of severity of MS. Of course, older age increased your odds ratio, as well as being male, Black race, cardiovascular disease, use of steroids and corticosteroids in the last few months, and also if you'd used one of the, as I said, the B-cell depleting therapies like rituximab, that did have a 4.5-fold increase in hospitalization. And so again, many of these characteristics are similar to sort of the general US population that I saw show you in the previous slide. But again, some of these characteristics are very specific for our MS population. Next slide, please. So when we talk about sort of prevention, I think there's all different aspects of prevention. We talk about prevention where, of course, if you're sick, you stay home. If you go out, you wear a mask, you socially distance. And now we have a new tool in our tool belt, which is vaccines. And, vaccines, I have to say, it has been one of those things where I could not have imagined that we would have vaccines available within a year, a little bit over a year plus off sort of this virus coming on stage. I think it really gives credit to some of the amazing scientists, brilliant scientists that are out there. And using some of the technology that we had probably used for other purposes and repurposing them for vaccines. And so right now, if you look sort of across the globe, not every country looks the same. There are countries that have access to different types of vaccine. Here in the United States, we have access only to the Johnson & Johnson, the J&J, the Moderna, and the Pfizer vaccine. But there are other vaccines. There's the AstraZeneca vaccine, which uses sort of a chimp adenovirus, just a normal harmless virus, and uses it as a vector for the viral protein information, the spike protein. There's Novavax, and then there's the Russian vaccine Sputnik, which uses an adenovirus vector also. And again, there are a lot of vaccines that we probably will never see here in the United States. We do probably are getting to a point where we're getting to a surplus of vaccines in many areas, but that's not true around the world. When we think about the Moderna and the Pfizer vaccine, and specifically the Pfizer vaccine that requires extra cold storage, it's probably not a vaccine that is going to be available to be given in poorer countries where there's just not the ability to have cold chain and to be able to get people vaccine in poorer areas that may not have electricity and so forth. And so there's going to have to be sort of a hodgepodge approach to getting vaccines to the rest of the world, because the mantra that I think all of us believe is that disease anywhere is a threat to someone somewhere here. And so it doesn't mean that just because everyone in Oregon gets 70% vaccinated, that if there are other places around the world that are not vaccinated, it just takes a hop and skip and a jump on a plane to come here. And of course, that can, increase the risk especially for those who are not vaccinated. Next slide. Next slide, please. Oh, thank you. So, as I said, there are two vaccines. There is the Pfizer and the Moderna, which are the two mRNA vaccines. They are given in 2 doses. Actually, tomorrow I have a vaccine clinic, so we're still kind of trudging along and getting vaccine into community arms. Pfizer is given typically about 21 days apart, and we know that this is about 95% effective. Then there's the Moderna vaccine, which is also given in 2 doses, and that's about 28 days apart. There's a little bit of wiggle room around kind of how far you can give those vaccines. We know that if you have to get a 2-dose vaccine, the second dose may be given up to 42 days, 6 weeks later, after the first dose if necessary. And the reason why I just highlight this is that when we talk about sort of the delay or the possible timing of vaccines in our disease modifying agents, this might play into when someone might choose to get their dose or choose to get their first or their second dose. Next slide. So as Dr. Spain pointed out, which is great, we have a really remarkable immune system. And, the way the mRNA vaccines work, of course, is that it looks basically genetic material called mRNA, which our bodies produce just tons and tons of mRNA every day. But we have been able to sort of make an mRNA particle that looks like the spike protein. And that mRNA particle needs to be protected. It's very delicate. And so it's protected by a little fat bubble, little cholesterol bubble. And that cholesterol bubble then gets taken up by our cells when you get your vaccine. So you get your vaccine, your cells take up the little fat bubble. The cells read the information. I think about it like a Post-it note. They read the information on that mRNA. Like a Post-it note, they tear it up. It doesn't hang out in your body forever. And once it reads that information, it follows the instructions and makes spike protein. That spike protein is recognized as something foreign. It's presented on the surface of these cells, and your body, as it normally does, says, this is not us, and makes, an immune response against that. And that immune response may come in the form of both B cells and T cells. And the most important thing is the memory B cells and T cells. And so again, this technology has not been, it's not new. This technology has been used in cancer treatments in the past. But I think what is new is, again, using the ability of mRNA to actually make or to create vaccines. The reason why I think this is also important is that, as Dr. Spain highlighted, that, if we are sort of depleting some of the systems associated with the normal B cell and T cell responses, how then how do these responses affect people's ability to develop an adequate memory system for our vaccines? And so I think that's one of those things that I think hopefully we'll be able to kind of flesh out later in this talk. Next slide, please. So the Johnson & Johnson vaccine is a little bit different. It is using a viral vector. As I said, it's using something called an adenovirus, which is a normal, really harmless virus. And what the scientists have done is really scooped the insides of the adenovirus out and basically put in the instructions to make the spike protein. That then gets taken up. The virus tries to replicate, and when it replicates again, it sort of injects its DNA. That DNA then gets read and makes mRNA, and then the whole process starts where that mRNA then makes protein. Protein is presented. Protein stimulates that immune response, and that immune response is then lived to the long-lived B and T cells. And so this is approved, of course, for our 18 and older folks. I think the advantage of the J&J vaccine is that it's 1 dose. And I think one of the things that we know for all of our vaccines is that they all prevent moderate and severe disease. It's highly effective, I think, for 85% of all strains. And one of the things that I think people underestimate when they talk about the J&J vaccine is how well it was sort of tested against some of the variants that we see out there. So it was tested against the South African variant and found to be 57% effective. The United States was 72, and then Central and South America was about 66% effective. And this is effective versus effectiveness. So effective means that you could, gotten tested and you still found to have COVID. But the question goes into effectiveness in the general community is that after you get your vaccine, do you go on to have severe symptoms? And we know again that getting these vaccines really does prevent you from having, for the majority of folks, getting severe symptoms. Next slide. So kind of what do we expect when you get your vaccine? This is something I talk to folks about all the time, is that so the side effects, of course, are things like sore arms. Systemic effects can be things like joint pains, headaches, fevers, muscle aches, tiredness, chills. I will highlight that specifically for the Pfizer vaccine, not the Moderna yet, but the Pfizer vaccine, the Pfizer got approved for a younger age group from age 12. And there is a signal that it might have a rare cause of some pericardial or myocardial inflammation seen in young males. This is still a moving target. No one's completely sure what to make of this signal. The FDA has just basically gave sort of a warning, but it's still not something where we're still telling folks not to vaccinate kids. Because we definitely think at this point that the vaccine's benefits outweigh the potential risk, as this is such a rare side effect. What specifically for the Johnson & Johnson vaccine, we know that just like the Moderna and the Pfizer, you can have just a local site reaction where you get your vaccine, sore arm. People may get headaches, fatigue, and sometimes body aches. The thing that I think initially raised some concerns around the J&J vaccine is that in some folks, and specifically women of childbearing age, there was a signal that it might have increased risk for getting clots, and clots in really weird areas, clots in certain areas of the brain as well as areas of the abdomen. And we're not completely sure what this looks like. We think that this may be almost like an autoimmune reaction to sort of the vaccine rather than the vaccine actually causing clots itself. So we have something called the body sees the vaccine, it sort of develops this abnormal response, and in developing this abnormal response to the vaccine, the body then sort of causes clots to happen as it sort of fights against this response. So again, it's still more to be developed, but I think all of us would still agree universally that the benefits of the vaccine outweigh the risk. For the I think now 15 cases or so that probably are seen. Millions and millions and millions of doses of this vaccine have been given. And I think this really says something about our surveillance system that, we can have, very, very minute, small cases around the entire country and pick it up. And so I think really says something that, people are alert and aware about this. And hopefully this does not negate people's want to actually get the vaccine. Next slide, please. So what about getting the vaccine and being able to transmit? I know lots of folks probably on the call are looking forward to seeing relatives, seeing grandchildren again, seeing kids. And we know that one of the things is that being vaccinated, being in the vaccinated group does have certain benefits. Of course, I said it does decrease the risk for severe illness. And, as the CDC has given guidance that vaccinated people who can gather en masse, I think we understand that vaccines prevent illness. We know that probably when someone gets vaccinated, there's probably a decrease in the amount of virus that someone can actually shed. So if getting a vaccine doesn't 100% guarantee that you won't get sort of COVID infection, you can still probably get COVID. The question is, do you get symptomatic COVID? Are you going to end up in the hospital? And so if you're vaccinated and you unfortunately get exposed to COVID and I was to swab you and you're positive, are you going to transmit that to someone else? And the studies that are coming out, there was a big, large study out of Israel that showed that vaccinated people have less infectious particles in their respiratory system if they do happen to get COVID. And so again, wearing masks, especially if you're unvaccinated, is really important because, you know, it doesn't guarantee that someone who's vaccinated won't transmit that virus to you, even though, again, it's probably less likely if they, you know, as compared to if they were not vaccinated. So socially distance is really important. It's also really important. We also know too that, you know, someone who is immunosuppressed may develop maybe a less robust sort of immune system and may transmit more copies of the virus. And so again, that may make someone sort of temporarily sort of contagious if they were severely immunosuppressed and infected. And so again, you know, this is still a growing field. There's still a lot of data that needs to be investigated, but we know that, again, getting a vaccine is important. Next slide. So one of the things we know too, and this is a question that comes up often in our vaccine clinics, is, well, I want the Pfizer, or I want the Moderna, I want the the J&J vaccine, and I'm of the opinion that it's vaccine in hands. Whatever vaccine you can get, you should get. We know that looking at the 95% and the 85% and comparing these percentages, these effective percentages, it's probably not a fair way. You're sort of comparing apples to oranges. The thing that's really important to go, of course, is that it prevents people from getting symptomatically sick and ending up in the hospital. The reason why it's also not a fair comparison is that we know these vaccines were developed at various times. And so when the Pfizer and the Moderna vaccines were developed, they were developed against sort of the original, sort of, would say, the Wuhan strain of the virus. And so at that time, there were probably not a lot of variants circulating. But by the time we got around to the J&J vaccine, there were more variants circulating, including the UK variant and, of course, the South African variant. And so comparing the virus's effectiveness of the vaccine's effectiveness when you have sort of a different metric is probably not a fair comparison, but so we definitely don't want to use that. Another thing too is that we just don't know about the durability of the vaccines. You know, is the J&J vaccine going to last longer because it's a adenovirus versus the mRNA vaccines like Pfizer and Moderna? We just don't have enough information as yet. And so again, it's again vaccine in arms, but more information to come. Next slide. So, what about getting a vaccine if you've already unfortunately gotten COVID? We know that people who've gotten COVID in the past can get COVID again. So getting a natural infection does not necessarily preclude you from getting a new infection. So getting vaccinated is still really important because we know that the immune response that's produced by getting a vaccine is actually much more durable than, say, natural immunity. And so what happens when someone gets COVID infection is that your body produces all sorts of antibodies to sort of fight the infection. Some antibodies are sort of effective and some are not. What you're really looking for is neutralizing antibodies, because those are the ones that will actually stop the virus. And so, you know, you may produce, you know, say you produce 100 you know, antibodies or so, just picking something, and you know, out of those 100, you know, 10 of those are the neutralizing antibodies. Really, what you want are those neutralizing antibodies, because that's what we want. The other sort of, you know, 90 antibodies, they may be somewhat effective, but they may not neutralize the replication of the virus. And so really what you're looking for is neutralizing antibodies. So getting the vaccine, even after you've had COVID, is still important because of the durability of that immune response. Next slide. So what does it mean for variants? I think as you turn on the news, what you're watching, whatever show you're watching, you hear about variants and mutations and mutants. It sounds like something out of a bad science fiction novel. We know that the virus is trying to find ways to evade our immune systems. Um, uh, these changes, I think about it as the vaccines as sort of, and the virus like a lock and a key. Our vaccines are the key, and the lock is the virus. And so what happens when that lock changes is that you may have slight changes. And I don't know if you've ever known that sometimes you'll find a key that just doesn't work. It will work, but it just doesn't work as well. So you sort of have to jiggle the key a little bit. So as that lock changes, as that mutant changes, that key will become less effective. So we don't want severe variations in that virus. We don't want severe variations in that spike protein, because there potentially could be a time where that lock and key match just does not work. That hasn't happened so far with any of our vaccines. Our vaccines still seem to work, even though the lock has changed slightly with those variations. And so again, really important again to kind of keep monitoring this. We did not have a really good surveillance system for monitoring variants in the United States, and so we're still behind the times in terms of getting this up to speed, but we're getting there. Other reasons that we get variations in this lock in this virus is that people, high transmission of virus between person to person. So in areas around the country that are just not vaccinated, this is a risk. And, one of the things I always tell folks is that I'm less worried about, people may talk about the UK variant or the Delta variant or the Brazilian variant. I'm worried about our homegrown sort of, Portland variant. If there are enough people in certain parts of Oregon that just don't get vaccinated, we can develop new mutants. It's just a matter of viral kinetics. So viruses can replicate between people with repeat infections. You can have more viral changes in people who are immunocompromised, because as you can think, if the immune system is sort of trying to attack the virus and the virus is kind of recognizing this, and you have escape mutations, then you can develop these mutants. People who have partial immunity, so if you get one dose of the COVID vaccine and then unfortunately you don't have real immunity then, and you sort of have partial immunity, or you've gotten one of those monoclonal or convalescent plasma treatments, that can sometimes help develop mutations. And so again, the really, really important thing at the end of the day is to get, if you're getting your J&J one shot, or of course, if you're getting your Pfizer or Moderna, get both vaccine doses, because this is what will prevent the emergence of new variants. Next slide, please. And this is just a quick slide just to show you sort of what we're looking around the country. As you can see, there are some states that are just really not doing well. I look for the orange. Oregon actually is not bad as compared to just looking at places like Wyoming, where the vaccine rates are just much lower, and that's no discredit to Wyoming at all. But again, as I said, having illness anywhere, having infection anywhere is going to be a public health threat to everyone. So, we live in sort of borderless states. And so again, at the end of the day, we need everyone to get vaccine. Next slide. So when we kind of get to the vaccines and recommendations, one of the things we know is that there are a lot of recommendations that have come out, and specifically the ones that I'm going to highlight are taken from the National MS Society. So what they've recommended is that getting any of the vaccines, so again, the whole policy of vaccine in arms, whether or not you get the Moderna, the Pfizer, or the J&J vaccine, just get it. So any of the 3 authorized vaccines are safe to get. There's no vaccine preference for those living with MS. The risk of COVID infection far outweigh any potential risks that come from the vaccine. I will highlight I will highlight some of this further in some other slides, but most of the disease-modifying therapies are not expected to affect the responses to vaccine. And also, the timing of the vaccine can depend on when it's available to you. So when you get your vaccine versus when you get your DMT, there may have to be some timing in between, and I'll highlight that. Next slide. Next slide, please. Oh, thank you. So, what do we think about for, antibody testing? I know that's a sort of a growing, metric for people who've gotten a vaccine and having antibodies. One is that first, I just want to highlight is that as I talked about, what you really need to measure is neutralizing antibodies. And most of our antibody tests are just measuring just generic antibodies. So getting a positive antibody test is not necessarily a marker of immunity. So it's just a positive result. And really what we need is um, um, looking at neutralizing antibodies. I know that certainly of the DMTs, such as rituximab, arculizumab, I butchered that, fingolimod, and some of the other um, therapies may have reduced or affect sort of the ability to produce detectable antibody to some of the vaccines. Um, and so if you take one of these DMTs and you take an antibody test, it may show a decreased or undetectable antibody level. As Dr. Speen talked about, we do have some of our deep B cell depleting therapies like Ocrevus and rituximab that may impact some of this critical immune response to fighting infections. The good thing, though, is that especially so for some of the B cell responses, it's not totally gone. And we do have sort of other parts of our immune system, our T cell responses that also fight viral infections. And so it's not a zero-sum game. There are other parts of our immune systems that can sometimes help fight infection, even though, again, some of this might be reduced. Next slide. So what about getting MS exacerbation and getting COVID-19? So one of the things that I think we know about is that having an infection can sometimes trigger MS. But again, there's no clear published data that COVID-19 itself does this at a higher rate. And the most important thing, again, if you're thinking about getting a vaccine, is that there's no evidence as yet that getting a vaccine can trigger an MS flare or a relapse or have any impact on long-term disease progression. Next slide. So what are the things associated? What should you do if you are on one of these medications? So this is sort of, again, information that came from the National MS Society. And basically, again, if you're on some of the DMTs, such as the interferons, they have stated that they are unlikely to have a negative impact on COVID-19. If you're on other medications such as Mayzent or some of the other DMTs, there's no increased risk of more severe COVID-19 symptoms. But if you go into the B cell depleting therapies, the rituximabs and so forth, there may be some of the increased risk of having more severe COVID symptoms. And again, it sounds like from Dr. Speen's talk that, some of the other medications like Mavenclad and so forth are still new. And so again, more data is probably needed around how it's going to impact the severity of someone getting COVID. Next slide. What about timing of the vaccine? So we know that, if you're taking one of these interferon therapies or so, do not delay starting any of these medications in order to get the vaccine. And so again, this should always be a conversation with your MS provider. And of course, if you're taking any of these medications, no need to adjust the dosing or frequency for the vaccine. Next slide. If you are taking one of the newer ones, so this is again Lemtrada and Mavenclad. Again, the recommendation from the MS Society is that the second dose of the vaccine should ideally be ideally should be 4 more weeks prior to the start of the medication. If you've already had, or if you've already on these medications, consider getting the vaccine no earlier than 12 weeks after the last dose. And of course, the most optimal timing is 24 or more weeks after the last dose. And if you're resuming the medication, to wait 4 or more weeks following the second dose of the vaccine. So again, this does come up to some timing. We don't want anyone, of course, to delay the ability to get your vaccine, but if you do have the ability to sort of do your calendar around kind of when your dosing is, then these are some of the considerations to take in place. Next slide. For the other types of vaccines here, Mayzent and so forth, I mean, the other types of DMTs, ideally it is to get the vaccine, get vaccine second dose 4 weeks more before the start of these medications. And of course, if you're already on these medications, to continue these medications as prescribed and to get the vaccine. Next slide. And then again, going to sort of the rituximab and biosimilars and the Ocrevus, that again, these are B-cell sort of depleting therapies. Consider a second dose of the vaccine 4 weeks or more before the start of the medication. And if you're already on these medications, to consider getting the vaccine 12 weeks or more after the last DMT dose. And of course, to resume your medications 4 weeks or more after your second dose of vaccine. Next slide. And then there's Kesimpta, which they kind of called out here. They said, consider second dose of the vaccine 4 or more weeks prior to start off your Kesimpta. If you're ready on this medication, wait 4 or more weeks after your injection before getting the vaccine. And then again, resume your Kesimpta 4 or more weeks after your second dose. And again, this should always be a conversation with your MS provider. Next slide. So what about steroids for people who may have flares? And what the MS Society has recommended is that you should, if possible, wait 3 to 5 days after your last dose of high-dose steroids before getting a vaccine. And again, this is about blunting the immune response that we need you to have to the vaccine. Next slide. So in summary, the data does not suggest that MS itself increases risk for more severe outcomes for COVID-19. We do think there's probably a lot of intersectionality between older age, heart disease, and other things that can be a big risk factor. The data also does not suggest that the vaccines will increase things like MS flares. We know that some of our DMTs will have it will sort of lessen some of the immune responses in people who may get a vaccine, and may, sort of predictably, may increase risks for infections in general. And again, sort of the timing of getting that DMT sort of might help maximize your response to getting a vaccine, such as delaying your second dose or so forth. So again, this is I feel like we're building the plane and flying it at the same time. But hopefully this will provide some guidance as to clinical monitoring and guidance for clinical outcomes. So thank you very much. And next slide. Perfect. All right. Well, thank you very much for listening.
Dawn, are you going to come back?
Hello. Yes. So we are going to, Ken, if you're able to share that break slide. So we are actually going to be starting back at 11. We're running a little bit behind, and so we're gonna make sure people get breaks. And I know people need to stop, stretch, grab a snack perhaps. I just wanted to let you know that we are going to be, we'll be able to make up some time in with the next 2 speakers. And so we'll come back at 11 for Dr. Pierce's talk on cognition, healthy brain aging. But first, I just wanted to let folks know that the virtual exhibitors are available. I'd like to remind people that the links are provided in the description of the YouTube channel and also in the exhibitor email you would have received yesterday. And it's for Biogen, Genentech, and Novartis. And if you visit the exhibitors, don't forget to get a code word. Each of the meetings has a code word for the OHSU drawing that we'll be doing at the end of the program. And so with that, I will go ahead and we will let you all have a break. And again, please reach out to the exhibitors, get some information if you like, and we will look forward to seeing you at 11 a.m. Thank you.
Ken.
Yes.
Can we talk here or no?
This is still connected to the live stream, but we can create a breakout room if you want to chat.
Sure. Ken, are we live again?
I don't believe so. I'm just up.
We are, although do you want to
Okay.
give it a little longer? Because I could use a minute or so.
Yeah, I think definitely it's okay.
Great. So
I think
yeah, those that are listening live still, we'll give it a few more minutes.
Absolutely. I think we can shoot for 11:05. Hello, everyone. I just want to check with our technical support people. Are we good to go? All right, awesome. So again, thanks for your patience, everyone. We had a little bit of technical issue, but I hope everybody's able to join and ready for the next section, and you had a break. So we will, first of all, I think I want to say thanks to Dr. Evans, who just gave the talk a few minutes ago, and thanks for an outstanding overview of the COVID, where we are right now, and the vaccine, and why we should be getting vaccines and trying to prevent infections, amongst us, so that we can get rid of this pandemic as soon as possible. And of course, people who have had questions, who have sent the question by email, we will be answering those questions and in the Q&A session. So please keep sending those questions to Dawn, as she has sent the link to you. And with that, I would now like to invite our next speaker. Again, extremely happy to have her with us today. She is an outstanding clinician, Dr. Amy Pierce, an associate professor of neurology at the School of Medicine at OHSU. She's the director of the Clinical Care and Therapeutics Program of OHSU's Latent Aging and Alzheimer's Disease Center. Dr. Pierce did her medical schooling from Columbia University, did her residency in neurology from University of California, Los Angeles, and did her fellowship in geriatric neurology from San Diego VA, as well as UC San Diego in La Jolla. Her interests are patient care and clinical research for patients with dementia, including Alzheimer's disease, dementia with Lewy body, and frontotemporal dementia. And today she will be talking to us about cognition and healthy brain aging in people with multiple sclerosis, which is really a very commonly asked and very common problem for our patients. So with that, I would like to welcome Dr. Pierce. Dr. Pierce.
Good morning. Thank you, Dr. Yadav. And looks like we jumped ahead a little bit on my slides, but I could jump in here if this is where we should start. So in any case, it's really an honor to be invited
Amy,
to, yes.
I think the original slide, it's okay to start from where you wanted to start.
Okay. I don't know if we can go back to my first slide. This is number 5, but
can we go back to number 1?
Kenneth, can you please back up to the first slide of Dr. Pierce?
It's all right. I think technical issues, it's all right.
No. Oh, we're going forward. Okay. Okay.
All right. Perfect.
This will be fine. Thank you. Okay, so thank you so much, Dr. Yadav. I'm really glad to be speaking to this group. I think this is a wonderful program that sounds like it's been a great tradition of the OHSU MS Center over the years. I love speaking with patient audiences, and I've already learned so much this morning. So this has been a treat. So we can go to the next slide. A few disclosures. So I am a site principal investigator for several phase 3 Alzheimer's disease clinical trials that are funded by several pharmaceutical companies. And I should say I spend about half of my time seeing and taking care of patients with cognitive impairment. And the other half of the time is spent on research, developing new treatments for Alzheimer's disease and other cognitive impairment disorders. Go to the next slide. Our objectives today, I'd like to define the cognitive changes that arise in patients with MS, review the treatment approaches for cognitive impairment in MS, understand the age-related cognitive changes and the symptoms of Alzheimer's disease, consider if there may be some overlap between MS and Alzheimer's disease, and then discuss healthy brain aging strategies. Next slide. So first, we'll cover the cognitive changes arising in MS, and we can go to the next slide. So first, just wanted to review what we're talking about in terms of cognition. So it's a word that's stated often, but cognition refers to the process of learning and understanding. And the very interesting and fascinating thing about the brain is that all of the aspects of cognition are to some extent localized to specific areas of the brain, yet all of the aspects of cognition do require high levels of connection and integration among the lobes of the brain. So just to point out, here we have the 4 lobes of the brain in different colors. So the frontal lobe is in red. Frontal lobe is important for motor control, problem solving and reasoning, judgment, speech production, planning, morality, social skills, and personality. So, and you can see that the frontal lobe is a very large lobe in the front of our brains. In green is the temporal lobe. Temporal lobe is very important for hearing and auditory processing, language comprehension, and memory. And memory impairment is one of the most common complaints as we get older. The parietal lobe is in yellow. Parietal lobe is very important for attention, understanding the sense of touch on our body, as well as our body's position in space. In purple, we have the occipital lobe, which is important for vision and visual processing. And the cerebellum is a smaller anatomical structure in the brain, which is not one of the major lobes of the cerebral cortex, but the cerebellum is very important for balance and coordination and can be affected in patients with MS. And again, the point is that cognitive functions are very highly localized, yet they also require high levels of connection and integration. And all of the connection and integration is mediated by the white matter, so the wiring of the brain. And as we know, MS is a disease which traditionally was thought to affect the white matter to a greater extent, which is certainly the case. But we also now know that MS is also affecting the gray matter, or the lobes of the brain as well. So we can go to the next slide. Cognitive symptoms are very common in patients with MS. And so it's important to note that these symptoms can be perceived by patients and detected on testing. Sometimes, however, it requires very detailed neuropsychological testing. Neuropsychological testing is extensive cognitive tests, which are normed based on age and education level. And if patients with MS perform neuropsychological testing, up to 60% of patients may have some deficits on their neuropsychological testing. The most common symptoms that are noticed in patients with MS can be difficulties with attention, processing speed, so the speed that an individual can respond to questions and make decisions. Executive function. So executive function are those functions mediated by the frontal lobe, and the functions that we would hope our executives have, which include good judgment, delayed gratification, problem solving, and then short and long-term memory are also common symptoms reported. In many cases, patients with MS may have some minor or major cognitive symptoms, but they're able to compensate. But sometimes the cognitive symptoms of MS can become very significant and affect aspects of daily life, like the ability to run a household, participate fully in society, or maintain employment. So it is really important to realize that cognitive symptoms can become disabling in patients with MS, just as the physical symptoms can. In general, patients with relapsing or remitting MS have better cognitive performance than those with progressive MS. And also cognitive decline in MS correlates with several factors, including length of time with disease and cortical lesion number and volume. So the amount of lesions in the brain, the total volume of the brain that's affected by lesions, and especially the type of lesions which are considered T1 holes, which are not the white spots, but if you look on a different MRI sequence, if there is actually loss of tissue there rather than just a plaque. And cortical atrophy or shrinkage of the brain. So these features on brain MRI can be more associated with cognitive symptoms in patients with MS. Next slide, please. In addition to the brain lesions found in MS, there are many other factors that arise in patients with MS that can contribute to cognitive symptoms that are experienced. And so, of course, fatigue which refers to physical or mental exhaustion unrelated to the amount of activity performed. So fatigue can affect up to 86% of patients with MS, and it can be physical or mental. And certainly if someone is fatigued in either fashion, that can impact their cognitive performance and abilities. Depression is common in patients with MS and with patients with any chronic disease. And in fact, there is a phenomenon called pseudo-dementia of depression, whereby if someone is experiencing depression, they may also have cognitive impairment, and their cognitive impairment may be more debilitating to them than the mood aspects of depression. So it's important to screen for depression in someone who's having cognitive complaints. Anxiety can affect cognitive performance. Pain can as well. If someone is coping with severe pain, it's very hard to concentrate and form new memories. And then, of course, disrupted sleep. Sleep can be disrupted for many reasons in patients with MS, including muscle spasms, pain, urinary symptoms leading to frequent urination, waking a person up during the night. Some patients are on stimulant medications for their fatigue, and that can also disrupt sleep, as well as anxiety and depression can disrupt sleep. And sleep disruption can really impact cognition as well. And then finally, sometimes medicines that patients are on for MS, like sleep aids or like muscle relaxants, can worsen cognitive symptoms. So all of these other factors can contribute to cognitive changes in people with MS aside from the MS itself. Let's go on to the next slide. So the treatment approaches to cognitive impairment for patients with MS we'll cover next. Please go to the next slide. The first approach, certainly if possible, address the contributing factors. So the factors that we just covered, if possible, addressing the fatigue, depression, anxiety, pain, disrupted sleep, and medication side effects. That's a very important approach. In terms of pharmacologic management of the MS itself, there have been some large studies or meta-analysis of numerous studies of individual drugs which show a small to moderate positive effect on long-term cognition on patients with on DMTs, disease-modifying therapies. So certainly working with your MS clinician, identifying the appropriate disease-modifying therapy and continuing on that as prescribed may have some benefits to long-term cognition. There are a few medicines which are used for patients with Alzheimer's and other forms of dementia. For example, donepezil and rivastigmine. These medicines have specifically been tried in patients with MS, but they have not consistently shown a benefit for cognition in patients with MS. So we don't typically use the Alzheimer's medicines for patients with MS and cognitive impairment. Looking at non-pharmacologic treatments for cognitive symptoms, the approach there is generally compensation for cognitive symptoms as an accommodation. And so here, staying very organized and assessing your individual life to seeing what you can do for cognitive support is important. And so many personal organization strategies like relying on alarms, written reminders, recording appointments with doctors or other important conversations can be very helpful. Pacing of activities is important. So if fatigue is a significant issue with affecting an individual's cognition, taking regular breaks or timing activities during the day that are cognitively strenuous can be helpful. And then looking into work accommodations can be very helpful. So we have all become very much more accustomed to telework during the pandemic, and that can be quite helpful for patients with MS and cognitive impairment. So allowing just more comfort and accommodations to get the job done. And then job sharing can also be a good approach as well. And finally, cognitive rehabilitation. So this would be a formalized rehab program or that's generally done with a cognitive therapist or occupational therapist. These studies of cognitive rehabilitation have shown mixed benefits overall, But if any aspect of cognition seems to be the most benefited by cognitive rehab, it may be memory. So considering cognitive rehab could be of help. And cognitive rehab is sometimes administered face-to-face with a therapist, but of course, there's been a lot of emphasis on developing telehealth delivery of cognitive rehab, which is under study right now. Let's go to the next slide. So I'm going to give just a little bit of background on age-related cognitive decline in Alzheimer's disease as distinct from cognitive impairment in MS. And the reason I'm going to do that is because in reality, this is very common, age-related cognitive decline as well as Alzheimer's disease. And we need to have that background because certainly patients with MS, as they get older, could potentially be at risk for developing a second disorder like Alzheimer's disease. And in fact, we are all at risk of developing Alzheimer's disease as we get older. It is unfortunately a common condition. So let's go on to the next slide. So there, aside from Alzheimer's disease, there are some cognitive changes that occur just with normal aging. So even with the healthiest brain, our cognition at age 100 is different than our cognition at age 50 or 20. So the aspects of cognition which change with normal age, even with healthy normal aging, there can be some changes in attention, word finding skills, and short-term memory. There are some aspects of cognition that can be maintained or improved as we get older, and that includes language performance, visual spatial function, executive function, and long-term memory. And so the key is with normal aging, activities of daily living remain unimpaired. So as we get older, we can all compensate for these cognitive changes with normal aging. However, as we get older, tip of the tongue phenomenon, where a word doesn't come to you when you need it, but it comes back to you later, or misplacing personal items and finding them after the fact can be very common. This can all occur with normal aging. Let's go to the next slide. But it's important to realize that dementia is not normal aging. Next bullet. So the definition of dementia is that a patient has symptoms as well as testing that shows a decline in cognition. Next. As well as with dementia, there's a decline in day-to-day abilities compared to previous level of functioning. Next. And so these day-to-day abilities that we're looking at when we're evaluating someone with dementia, we're trying to determine if they're having any difficulty with their instrumental activities like employment, finances, medication management, appointments, driving, shopping, or cooking, or their basic activities, eating, dressing, bathing, or toileting. And so if their cognition is impacting their ability to perform these activities, then and there's been a decline in cognition that may be consistent with a diagnosis of dementia. It is important to note if it's a physical limitation that's impacting their ability to perform these activities, that would not be consistent with the diagnosis of dementia, but it needs to be cognitive impairment leading to a decline in daily living skills. Next slide. And so dementia is an umbrella term which again refers to a decline in cognition that impacts your daily living skills. It's important, if possible, to identify the cause of dementia. So there will always be a cause of dementia, some of the most more common degenerative forms of dementia are listed under the umbrella, including Alzheimer's disease, frontotemporal dementia, vascular dementia, Parkinson's, or Lewy body. There are many other causes of dementia, including more than 100, and MS itself can cause dementia as well. But Alzheimer's is the most common form of dementia. It's important to try to identify what's causing dementia if a diagnosis has been made. Dementia itself, in and of itself, is somewhat of an incomplete diagnosis. So ideally, we want to find out what's causing it, why did it happen, and how it can be treated. Next slide. This is just to show, as I mentioned, Alzheimer's is the most common form of dementia, but Alzheimer's arises in a continuum. And so on the x-axis is years, and on the y-axis is cognitive function. And in the dark line, you can see as we get older, with normal aging, there can be a little bit of decline in cognitive function. But in the dotted line is the pathway of Alzheimer's disease. So with Alzheimer's disease, there may be a long period where there are no symptoms or even just slight symptoms. That's called the preclinical phase. Then a person starts to develop mild symptoms called mild cognitive impairment, and then progresses to Alzheimer's dementia. And as you can see, then their pathway differs from just normal aging because cognitive decline is more significant and more rapid than with normal aging. Let's go to the next slide. Next slide. Just go ahead. Yes. So the key elements for diagnosis of Alzheimer's disease. Next. So the first symptoms next are short-term memory loss in Alzheimer's disease. So that may be forgetting conversations, repeating questions, forgetting recent events, but still remembering the distant past. Next. Other symptoms that occur include getting lost, difficulty with time, date, day or month, difficulty with names and words. Next. Alzheimer's usually comes on in an insidious manner. So that just means that creeps up on a person. They may not realize when it's initially starting. And there's a slow progression of symptoms over time. Next. And there are changes in day-to-day abilities in Alzheimer's disease. Next. One thing that can be helpful in Alzheimer's disease diagnosis is MRI. And over on the right panel, we see a normal brain with a hippocampus circled. Hippocampus is an important structure of the brain and the temporal lobes for short-term memory. And in Alzheimer's disease, there is shrinkage of the hippocampus. The hippocampus is gray, and then the dark black area is where there is just fluid, cerebrospinal fluid filling in where there's been shrinkage of that hippocampus. So that can be helpful in making the diagnosis. Next slide. The pathology of Alzheimer's disease. There's cerebral atrophy. So on the left panel, we can see a normal brain and then a brain of someone with Alzheimer's disease. So there's been overall shrinkage of the brain due to cell death, neuronal cell death. Neurons are the electrical brain cells. When you look at the brain of a patient with Alzheimer's under the microscope, you can see amyloid plaques. So these, this is in the middle panel, these little fuzzy brown plaques, which are sticky protein named amyloid that accumulates in the brain. You can also see neurofibrillary tangles. This is the right panel, the very dark flame-shaped proteins that accumulate inside the neurons. And they're composed of tau. And so in order to make the diagnosis of Alzheimer's disease on pathology, you need to see amyloid plaques, tau tangles, and neuronal cell death leading to brain atrophy. Next slide. So earlier this week, I had to update my slides because I thought there might be some questions or attention on this, and I thought this would be the best place to put it. So certainly on, I'm sure that many people saw the news on Monday, the FDA approved the first new Alzheimer's drug in nearly 2 decades. That was actually in 17 years ago when the last drug was approved. And let's go on to the next slide. So I'll just make a few comments about this, and I'm happy to take questions at the end in the panel, but I just wanted to say a few words about it. The new medicine is called aducanumab or Aduhelm. You know, our first 2 talks, there was just so much talk about antibodies, and finally we get to talk about antibodies with Alzheimer's disease. So aducanumab is a monoclonal antibody that binds to and clears amyloid plaques from the brain. There were 2 large phase 3 studies conducted called Engage and Emerge, which tested aducanumab in early stage Alzheimer's disease. There were several difficult aspects to the studies that were conducted. First, the dosing of the study drug was changed during the course of the trial. the trials were actually halted early because they failed futility analysis. So an analysis halfway through indicated that the drugs were unlikely to be a benefit, so the studies were halted. But then a reanalysis of the data after the trials were halted indicated that in one trial, which was called EMERGE, those receiving just the high dose of aducanumab showed slowing of progression of cognitive impairment by 22%. So that means essentially 4-month slowing of decline over the course of the study of 18 months. But there was no benefit seen in the second trial. And important to note that 41% of patients on the high dose had swelling or small hemorrhages in the brain, although most did not have symptoms of this. The FDA advisory panel, which is composed of experts in the field, neurologists, epidemiologists, statisticians, recommended against approval of this drug. But the FDA approved aducanumab via an accelerated approval pathway, which allows early approval of drugs that treat serious conditions and that fill an unmet medical need based on a surrogate endpoint. And so it is true that this drug clears amyloid or amyloid plaques from the brain, but it's not yet known that the clearance of amyloid will have a long-term impact on cognition. And in any case, we certainly hope that this approval spurs interest in Alzheimer's research, provides hope for participants and patients, and further study of aducanumab will certainly be needed. Let's go on to the next slide. Okay, a little bit of discussion about the possible overlap between MS and Alzheimer's disease. Next slide. So there are some interesting questions that come up. So of course, MS and Alzheimer's are two very distinct diseases. They both can impact cognition, but in different ways. But a question is, as patients with MS age, are they at higher risk of developing Alzheimer's? Or maybe at lower risk? Or maybe they're just at their normal risk associated with their age? And so this is a really fascinating question, and there are very few reports in the medical literature of patients with MS and Alzheimer's disease. And this is a major knowledge gap and must be a research priority. It's quite possible that not every case is going to be reported. Of course, that's not where the state of medical literature is, but it's very it's an under-focused on topic. Another thing that comes up is, how do we establish the diagnosis of Alzheimer's in a patient with MS? Because again, MS itself can cause cognitive decline and brain atrophy. And it's important to realize that worsening of cognitive symptoms in an aging patient with MS could be due to MS alone entering that progressive stage, or it could be MS plus Alzheimer's, or MS and another form of dementia. And so the way we try to figure this out, some things that can help include cognitive testing, cerebrospinal fluid analysis, and brain imaging. And so this is just a little chart that shows the typical cognitive symptoms in a patient who has cognitive impairment with MS versus the cognitive symptoms in Alzheimer's disease. So short-term memory can be impacted in both. In MS, we tend to see more problems with attention, processing speed, and executive function. And in Alzheimer's, we tend to see more problems with disorientation to time and place, word finding difficulty, and then executive function can happen, problems can happen in both. So again, that's judgment, decision-making, problem solving. Next slide. Brain MRI can certainly be helpful in the diagnosis of Alzheimer's and MS, although, again, as I pointed out, one of the hallmark characteristics of Alzheimer's is the hippocampal atrophy, that memory structure in the brain that tends to shrink down. MS brains are completely unique. There aren't such typical findings that are seen in patients with MS. Every person's brain is unique on MRI, but certainly we tend to see the white matter plaques. In this patient's brain, we do not see hippocampal atrophy. And then here are just some examples of the T1 black holes that can be associated with cognitive impairment in MS. Let's go to the next slide. Next. Okay, so cerebrospinal fluid testing This CSF testing can be helpful in the diagnosis of MS as well as Alzheimer's disease. So we're looking at different things though. In Alzheimer's disease, we can measure beta amyloid levels as well as tau levels. And so if these amyloid and tau levels are abnormal in a patient with cognitive impairment, that would be more consistent with Alzheimer's than MS. And of course, in MS, there are other features on spinal fluid like oligoclonal bands, elevated IgG index, which are not seen in patients with Alzheimer's. It's not 100%. There is, an overlapping Venn diagram, but sometimes the features in the spinal fluid can be helpful. And of course, this spinal fluid is checked by a lumbar puncture. And this is just to show that the spinal fluid is produced up in the brain, circulates around the brain, down to the spinal column. And so by measuring the spinal fluid, we can gather a lot of information about the health or the illness of the brain cells. Next slide. There are a couple of types of PET scans, which can be helpful in the diagnosis of Alzheimer's. They aren't often done or routinely done in patients with MS, but sometimes if a patient with MS is having cognitive impairment, this can be helpful. And so one type is called a FDG PET scan, fluorodeoxyglucose PET scan. This shows the activity in the lobes of the brain. Areas of high activity are shown in red, and areas of lower activity are shown in yellow, green, and blue. And these are images as if of a slice through the brain, as if the patient's lying on their back with their feet towards us. And so up top, we can see the typical finding in Alzheimer's disease, where the frontal lobes look good, but there's reduced activity in the parietal lobes here on the side, towards the back, and the temporal lobes on the side. So parietal hypometabolism, reduced metabolism in Alzheimer's. And then on PET scan, with MS, the pattern can really vary depending on where the lesions are and how the circuitry has been affected. But more typically, we may see frontal reduced activity in MS, and that goes along with that, the difficulties with executive function and processing speed. Next slide. There's a new type of PET scan which has recently become available, which is called amyloid PET imaging. And this allows us to detect amyloid plaques in the brain. A tracer is injected in a vein in the arm. The tracer circulates through the body, binds to amyloid plaque in the brain, and then can be detected by a camera. And on the left, we can see the amyloid plaques in the brain of someone with Alzheimer's compared to control. And so a patient with MS without Alzheimer's should not be showing a positive amyloid PET scan. And what's interesting, there's a large study called the Mayo Clinic Study of Aging. This is not a study specific for MS, it's just for aging and brain health, which is in Rochester County, Minnesota, and Olmsted County, Minnesota. And everyone who is over a certain age is invited to enroll, and all of their health conditions are tabulated. And then they get very detailed and advanced neurologic testing. And so some of the patients enrolled in the Mayo Clinic Study of Aging had MS. When they underwent amyloid PET scans, those patients with MS as they got older had lower amounts of brain amyloid on their PET scan than age-matched controls. So that sounds pretty good. Next slide. Okay, so I'm going to finish up my talk with a little bit of information about healthy brain aging. And this does harken back to Dr. Spain's talk as well. So this is great. I really love to see the focus on healthy lifestyle for brain health in patients with MS throughout the lifespan. And I really think that that is all very relevant to dementia prevention and prevention of Alzheimer's as well. So let's go on to the next slide. So the first thing to realize is that the #1 risk factor for Alzheimer's disease is age. And this we cannot control, but we have to be aware of. And just to show that at the age of 60, approximately 1% of the population is afflicted with Alzheimer's, but the rate doubles every 5 years after the age of 60. So certainly the #1 risk factor for Alzheimer's is aging. And so we can go on to the next slide. And so my first advice for preventing Alzheimer's disease is to stop aging. Okay, so that we can't do yet, but let's go on to the next recommendation. So a lot of patients ask about the familial risk of Alzheimer's disease. And it is true that an inherited form of Alzheimer's exists. This accounts for 1% of all cases associated with a mutation to one of 3 genes and is autosomal dominant, which means that if you have a 50-50 chance of getting that gene from each parent, and if you have it, you will develop Alzheimer's. But the other 99% of Alzheimer's cases, it's not autosomal dominant, but we do know that there is some aspect of genetic risk. So if you have a parent with Alzheimer's disease, your risk is 3 times greater than the general population who does not have a parent with Alzheimer's. And there's a stronger effect for having a mother rather than a father with Alzheimer's disease. Next slide. So the Alzheimer's disease risk factor genes have been looked at. The most common and strongest risk factor gene for Alzheimer's is called ApoE. ApoE is a lipid transport protein, and how it affects Alzheimer's is not fully known. There are 3 versions of ApoE, 2, 3, and 4. You get 1 copy from each parent, and if you get the E4, that's associated with a greater risk of Alzheimer's disease. Next slide. And this is just to show the approximate lifetime risk of Alzheimer's disease based on your ApoE genotype. If you have E2 or E3, you're at rather low risk, perhaps less than 10%. But if you have a copy of the E4, your lifetime risk goes up to 20%. Or if you have 2 copies, lifetime risk goes over 50%. But that's also to show that even if you carry 2 copies of ApoE4, not everyone will develop Alzheimer's disease by any means. Next slide. Again, you can have 2 copies of E4 or 1 and never get Alzheimer's disease. You can also get Alzheimer's disease and not carry any copies of ApoE4. And the current knowledge of ApoE status does not allow us to directly intervene to prevent Alzheimer's. And general Alzheimer's prevention measures apply whether you carry ApoE4 or not. So I don't generally recommend this genetic test except for research purposes, but many individuals do know their ApoE status based on requesting to know, or 23andMe or other online genetic platforms. So it's important to realize you may find this out, you may want to know, you may not want to know. Next slide. So number 2 recommendation to prevent Alzheimer's, choose the right parents or genes. Okay, again, we can't act on this, but let's go on to the next and then we'll see what else we can do. So there are some dietary recommendations for prevention of dementia. There are some general recommendations, and it's important to note, though, these are not based on randomized controlled clinical trials. We can't assign someone to one diet and another and follow them for their whole life and see what happens. So generally, this is based on asking people what sort of diet they're on and then looking at their risk. So let's go on to next slide. So there is an association with increased fish consumption and reduced risk of developing Alzheimer's disease. And so those who ate fish 1 or 2 times a week were associated with half the risk of Alzheimer's disease. Next slide. And so in general, we recommend a Mediterranean style diet, which involves eating fish, fruits and vegetables, olive oil, nuts, beans, and then red wine, but no more than 1 glass a day. So this is the Mediterranean diet approach. Next slide. And then also to note that midlife obesity increases the risk for Alzheimer's disease. So the group who are obese at midlife were associated with a 30% greater risk of Alzheimer's compared to those of normal body weight. So that's another important aspect. Next slide. So for keeping a healthy brain, eating a healthier Mediterranean diet, controlling obesity, and there's also some information that controlling diabetes over the long term reduces your risk of Alzheimer's and other forms of dementia. Next slide. a comment about hypertension. That's also very important to control. This is a model of the brain, which is showing the blood vessels of the brain. And so as you can see, it's incredibly beautiful, complex, very small, fine blood vessels in the brain. And hypertension can harm and injure these blood vessels and then reduce blood flow to the brain. So the brain only weighs 2% of our body weight, but uses 20% of our blood oxygen. So controlling hypertension is very important for brain health. Next slide. Next slide. This was published 2 months back. Lack of sleep in middle age may increase dementia risk. And so I think this is really important to think about. There is some understanding that during our deep stages of sleep, that allows the brain the opportunity to clear out amyloid in the brain. And so getting a good night's sleep is really important. Both for our overall well-being and maybe very important for the risk of Alzheimer's disease as well. So next slide. Getting a good night's sleep is important for brain health. Next slide. Head trauma. So there is some association that's shown that patients with head trauma are more likely to develop Alzheimer's disease late in life, as well as a different type of dementia called CTE, chronic traumatic encephalopathy. And CTE is the type of dementia that's associated with football injuries, concussions, that sort of thing. But aside from CTE, there may be some link between head trauma and Alzheimer's as well, and especially in people who carry that ApoE4 genotype. Next slide. Okay, so the advice here is, of course, to wear a helmet and protect your brain. And we can just skip through, fast forward through all the different types of helmets you may need to wear. Okay, good. And next slide. Cognitive activity in older people. This is very important. Cognitively inactive people over the age of 65 are greater than 2 times more likely to develop Alzheimer's disease. And keeping up a good social network is also important. Because assuming equal levels of plaques and tangles in the brain, a person with a greater social network was found to have better cognitive function. So keeping up good cognitive activity and social engagement and midlife and as we get older is important for brain health. Next slide. And this is just to show that lifetime cognitive activity is associated with reduced levels of A beta, amyloid beta, the plaque form in Alzheimer's, to show that people with on the y-axis is the amount of amyloid beta in the brain. Young controls had this amount, and the patients with Alzheimer's, some of them had low, but they had high levels of amyloid plaque in the brain. And then you can see for those with low, moderate, or high levels of cognitive activity, the amount of the amyloid plaque went down. So that's a good thing. Next slide. So just encourage everyone to keep up with mentally stimulating leisure activities as they get older and as they're younger as well. And there's not a specific form that is the best. It's important for you to find what you like to do and is stimulating for you, and to not do the same thing all the time, but change and keep your mind active in that way. Next slide. Okay, so keep your mind active is an important aspect of a healthy brain. Next slide. Last but not least, exercise. So 30 minutes of moderate exercise daily is recommended for adults, but only 26% of American adults get this recommended amount of exercise. So this is something that many of us need to do better at. Next slide. The cerebral effects or brain effects of exercise. There can be some effects on neurogenesis or production of new nerve cells, angiogenesis or development of new blood vessels, blood flow to the brain, as well as production of neurotrophic factors, which keep nerve cells alive. Next slide. This is to show that exercise decreases the risk for dementia. So the dark line is people who exercise greater than 3 times a week, and the dotted line exercise less than 3 times a week. And as you get older, those who remain dementia-free was higher in the people who exercised more than those who didn't. So this is important. Next slide. And in fact, there's been a randomized controlled trial looking at aerobic exercise, which is like cardiovascular exercise, compared to a stretching control group. And those who were in the aerobic exercise, the blue lines, had larger volumes of their hippocampus, the memory structure, over time than those who were in the stretching control group. And those with aerobic exercise even boost the size of their hippocampus. So we think that cardiovascular exercise is really crucial. Next slide. So last advice for keeping a healthy brain is to get regular exercise. Next slide. So can cognitive decline be prevented as we get older? We think that there are many factors that can be modified and that we can all do in our daily lives. And we think that physical inactivity is the #1 modifiable risk factor. And some people even say that sitting is the new smoking. So I think I'm sitting down right now. I feel like I should stand up, but I hope you can stand up at home. Next slide. So in summary, cognitive symptoms are common in patients with MS. Treatment may include disease-modifying therapies, treating the contributing factors, as well as cognitive rehab. As patients with MS age, they are at risk for developing age-related cognitive impairment and dementia. And much more research is needed to understand the overlap between MS and Alzheimer's disease. But no matter what, healthy brain aging strategies are important as we go through life and get older. Next slide. Okay, thank you very much, and I'll be on the panel later.
Thank you, Dr. Pierce. So I think we are running a little bit behind. What I was thinking that definitely will answer a lot of questions during the Q&A session, but for my part, which is the research update, I'll try to kind of, shrink it down. So Don, do you want to make any announcements right now?
Yes, thank you, Dr. Yadoff. I just wanted to make a couple comments. There's a few people that had issues getting into the exhibitor links, and I just wanted to remind folks that the exhibitor links are going to be available during the break times. And so if you try to join, you get a prompt that you can't join, please get out of there and try again. A lot of times it just needs to be refreshed, it sounds like. And then also, if we are having a little bit of delay for the break and panel time, we'll update as we go. So you take it away, Dr. Yadoff.
So Don, maybe what I was thinking,
Oh, yeah.
since I have only 15 minutes, perhaps we should delay the break time to maybe 12:15. Will that be too late? Or do you think that would be okay? Or maybe 12:10?
Yes, we absolutely can do that.
So I mean, so that we can accordingly, activate. Maybe we should use 12:10 as our time for break, and then maybe start the panel at 12:30. I hope it's not too late for the patients or the audience here.
Yeah, no, that should be fine, I think.
All right.
And it
Okay,
still
so
allows for an hour for the Q&A questions. We received a lot of questions so far and appreciate it.
Okay, so I think what we will do is we'll probably just push it by 10 more minutes now. And I know, folks, if you guys are hungry or please take a break. At least the advantage is that you're at home, where you can take a break anytime. So we will try to just push it further by 10 more minutes so that at least I can do my piece and then also have time for the exhibit and also for you guys to get a break. And then we'll go right into Q&A panel. And then if you need to extend that, we can extend that. So, all right. Sounds right? All right. Okay, thanks, Don.
Thanks.
So hello, everyone again, and then a research update from the Hill. So I think a big part of what we do at OHSU and at the Portland VA, our affiliated center, is research. So besides the clinical care that we provide to our patients and the education program that we do, research is a huge part of who we are and what we do on a day-to-day basis. The next slide, please. These are my disclosures. I'm supported by the Department of Veterans Affairs, Tax and Family Term Professorship in Wellness Research, National Institute of Health, MS Society, as well as the Patient Center Outcomes Research Institute. Next. So just to give you an overview of what it takes to do research at OHSU for our providers, for our researchers. So MS Center, as you can see here, is in the orange hexagon. And then we have very close relationship with the Veterans Affairs. So both of us have doctors who are actually funded by a variety of resources that include federal grants, that include National MS Society grants. So this is where the funding for the research comes mostly. And also big funding actually comes from donors, or the people who provide philanthropic support through the OHSU Foundation. So that also becomes, so all of these resources are extremely valuable to us to continue the research. So at OHSU and the VA, we have a variety of other sort of institutes or divisions or departments where we extensively collaborate. So for example, the Advanced Imaging Research Center, it's an institute within itself, a part of OHSU, but has the capacity for us to do a variety of very novel techniques of imaging, such as 7 Tesla MRIs, or using very novel 3 Tesla MRIs, or even for animal studies, there are 12 Tesla MRIs available. So those are really advanced imaging tools available to our researchers. Wallam Institute and Jungner Center are two research they are research institutes in itself, which basically the basic scientists, like, when they are looking into the nitty-gritty of how myelin is affected in certain way, how the oligodendrocytes, which are the cells which are making the myelin, how they are affected, and what can be done to tweak those. Those research are done on campus in our labs. And then, of course, we have this institute called Oregon Clinical Translation Research Institute, which is funded by NIH and provides a resource for the OHSU MS Center providers to be able to do research. We recently were funded by the NIH for this center, which is a newly formed center last year called Botanical Dietary Supplement Research Center, which also will add resource for us to do novel kind of investigations. We have biostatistics core, we have bioanalytical core, where we can analyze small molecules and sort of see how they can be used for the discovery of new products. For example, lipoic acid, like one of the products that I and Dr. Spain have worked on, was actually tested in the bioanalytical core at OHSU, where we were able to detect the blood levels and what the capsules contain. So this is extremely valuable source, from the get-go. We are also now collaborating with the Cancer Institute, the Knight Cancer Institute, for the bone marrow transplant study, which is being conducted at OHSU MS Center in conjunction with the transplant doctors. And then we have access to the exercise physiology lab. We have the Eye Institute, the KCI Institute, where our doctors can help us in doing novel research. And then, of course, we have other basic scientists who are doing research in microbiome, so where we can collaborate with them as well. Next slide, please. So in terms of the clinical portfolio of the MS Center as right now, wellness is a huge area of research that we have been working on for 10 plus, rather 15 plus years now. And that includes looking for an antioxidant, role of antioxidant in MS, or looking for diet in MS, looking for now exercise, how it impacts MS, and then whether exercise has the potential to not only improve mobility, but also can it actually remyelinate. So those are some of the things that we are really investing into. I'll talk briefly about the study which I am conducting myself with the funding from the Veterans Affairs Department about impact of vascular disease. We have heard a lot about vascular disease impact, like in Dr. Spain's as well as Dr. Pierce's talk, as well as the COVID talk that Dr. Evans gave, how important are these vascular diseases like obesity, hypertension, and diabetes, high cholesterol kind of things on health. And specifically, we are looking at how it impacts the health in MS people. Dr. Silverman is looking into, and I'll talk more about that briefly, about how the vascular disease can impact the eye health. And then we have other doctors like Dr. Cameron, who are looking into use of walking aid devices and walking aid programs in MS, how we can optimize that. And Dr. Cinda Hugo is a physical therapist. She's looking into how can we better evaluate the spasticity, and that can be that can also help in doing better research with the MS. So the current study, which is done in conjunction with NIH, is the transplant study, which I'm really excited about, and we'll talk more about in the next few slides. Next paragraph. I'm sorry, next slide. So these are the researchers who are doing clinical research at the MS Center. Myself, Dr. Cameron, Dr. Woolscroft, and Silverman, who joined us as a faculty last year. Dr. Spain, of course, and Dr. Lane, Dr. Bernard, and Cinda Hugos, and of course the Uber person or Uber mentor for all of us having Dr. Barrett. So, under his guidance, the center has thrived in doing all kinds of research. Next slide, please. Our fellows, they are, frankly, I think the torchbearer of what we have taught them so far and how they will take it to. So they're all involved in a variety of very interesting, very novel research, and wherever they will go, they will be taking that research, kind of tools with them to keep furthering this field. Next. And these are the research staff. Next. Next. So this slide was shown by Dr. Spain about the impact of vascular disease and MS and how it can impact the disability in MS. And again, emphasizing that having a presence of one or more of these vascular disease risk factors, whether it is high blood pressure, obesity, or diabetes, high cholesterol, heart disease, all of them can impact mobility and disability in MS. So I think that's something to really keep in mind. So with that sort of hypothesis and knowledge in 2010, we put together this project, which was looking at how in MS a person with MS who has these factors and who do not have these factors, how is the brain different? So that's what the next this project is going to be looking at. Next slide. So the purpose of this is to look at whether having these factors can change the brain metabolism in any way. And is there a connection between the brain metabolism and the disease progression or brain atrophy in MS? So we are looking at all of these factors, and then we will be, so this is a 3-year-long study where we have collected MRIs on 7 Tesla magnet. And we have captured like how the brain volumes are, what the disease burden is, like looking at specific lesions and counting them or like evaluating them as the time goes by over the 3-year period. And then we'll correlate that with the clinical outcome of disability and quality of life. Next. So this is sort of the schematic of the study. And what I'm presenting today is the at baseline. When we saw the patient for the first time, how were they different in their group? So we are looking at MRI, blood tests, some questionnaires, as well as looking at testing, cognitive testing, and doing the disability exams. Next. So at baseline, so we included 60 subjects, and out of the 60, we had 35 subjects who had one or more of these vascular disease factors, and the average age of that population is 56. And many of you, or some of you who are in the audience may have participated in the study. So thank you to all of them who have taken part in the study. And then, of course, we will be giving you the information as we analyze the data. And the people who are in the vascular disease negative, risk factor negative group, their average age is slightly younger at 52. Majority of the participants are females. And the three diseases which are, three disease states rather, which were the most prevalent in the vascular disease group were hyperlipidemia or high cholesterol, high blood pressure, and obesity. Those are the big ones, and majority of the patients were on disease-modifying therapies. Next. So what we are seeing here is, so the MRIs which were available to us for analysis at baseline were 52 MRIs. And so out of 60, 52 were analyzed, and 8 people did not really go through MRI for a variety of reasons. Next. So what we see here is the group on the third column, which is the group which had the vascular disease risk factor. They have higher body mass, which is expected because they are in that group. They also have proportionately higher waist circumference as well as thigh circumference, and they had higher levels of insulin, cholesterol, triglyceride. And what is was clear is at baseline itself, they had higher amount of disability. So they were more disabled as compared to the people who are healthier. Next slide. So what we have shown in the study, when we looked at the MRIs of these 7 Tesla MRIs of these subjects, we found that at baseline itself, the two groups were different. The people who had vascular disease factor, they had higher neurological disability. They also had lower brain volumes actually at baseline, and they had reduced brain ATP levels, or which is ATP is the product of mitochondria, which are basically energy cells, and ATP is adenosine triphosphate. It's just a molecule, which is where all of us get an energy to do anything. So without ATP, none of us can function. So what we are seeing here is the two groups are different in the brain ATP or brain energy reserves level at baseline. And frankly, I think at this time, I believe that the reduced ATP in the mitochondrial or the mitochondrial dysfunction that we are seeing in the vascular disease group, it probably is connected to the disability in some way in MS. So I think it's really important, as Dr. Pierce said, as well as Dr. Spain mentioned, that to focus on how can we stay healthy, how can we keep our body, whole body, as well as the brain healthy. Very important for MS2. Next slide. So the next study that we are, the next slides that we have right now is to give you an update on like what is happening as of right now today in terms of different diseases, disease types, research like in the different disease types. So the first which I would like to emphasize is the one which is happening in active relapsing MS, which is refractory. Next slide, please. When I say refractory, these are MS patients who have active relapsing disease. They are already on a disease-modifying therapy, but that disease-modifying therapy is not enough to control their disease activity. Hence, they're having either relapses, clinical relapses, or they're having MRI disease activity. So if any of you are in that category, transplant could be an option for you, but you have to meet very stringent criteria because autologous transplant is a risky procedure. But I think this study, which is funded by the National Institute of Health and Immune Tolerance Network, they are looking into whether at present the transplant, like autologous hematopoietic stem cell transplant, does it have similar efficacy to the best available therapies? And best available therapy for MS would include things such as drugs such as B-cell therapy like Ocrevus or rituximab or Lemtrada or alemtuzumab or cladribine. So those are the class of drugs that we are trying to compare whether an MS patient who already has disease activity on another drug, are they able to be controlled by the best available therapy or high efficacy therapy versus the transplant. So this is the comparison, and the study is actually being conducted at 20+ sites across the US and UK. And this is the website, the beatms.org is a website where anybody who's interested in this can go and see whether they could be eligible. So, and the basic eligibility criteria are like they have to be, MS subjects have to be in the age of 18 to 55. They have to have relapsing MS, but they have to have evidence of disease activity on a medication. So they cannot be off medication. All right. And the coordinator for this one is Kevin Christmas. But I think once you log into the website, you will be routed to the, if you are eligible, for example, you will be given the contact information to contact the center, and then you can come through the website. All right. So the next exciting study that is ongoing right now is for progressive MS. Next slide, please. And that's the lipoic acid study that Dr. Spain is heading right now. To give you background on lipoic acid is a over-the-counter. Initially, it was thought to be an antioxidant. It's still in the antioxidant category, but it may have many more roles than just like being an antioxidant. So we had, or our center had conducted, Dr. Spain was leading that study, looking at two-year study looking at impact of lipoic acid on progressive patients and whether or not there was any impact on the brain atrophy. And what she found was the chart that you're seeing in the middle where there are like a red line and the green line. So these are the results from the previous study which showed that there was significant slowing of the rate of decline in the brain atrophy in the people who are getting lipoic acid. So it's almost, if you look at the top line, which is minus 0.2% per year, which is a normal rate of expected rate of brain atrophy or brain volume decline in MS patients, versus the people who got lipoic acid had much lower rate of volume decline. So what we are in this current study, what is happening is we are trying to replicate similar results, but the focus is on clinical outcomes. So we are looking at, actually, maybe we can go to the next slide. So this particular study, which is happening right now, which is active and is funded by the Department of Veterans Affairs, it is looking at whether it can improve the walking capacity of MS patients who take lipoic acid. So it's a placebo-controlled trial. So neither the doctors nor the patient knows whether they're active or whether they're on the placebo pill. But that's what we are going to see at the end of the trial, how the two groups were different. So of course, confirming the results from the previous trial, and also to see whether lipoic acid subjects have improved walking and they have decreased fall. So as I said, it's a VA funded study. There are 5 VA sites. There are also universities which are 6 universities which are at sites, and the progress is actually pretty good. We are the target was to achieve 118 subjects, and it's almost there. So maybe roughly 20 more people are needed at this time to be. So stay tuned. This is a 2-year study, so results will take some time for it to be done and completed as well as then analyzed. So I think we will. So one more thing about lipoic acid is, so there was some hint that there could be some issue with the kidney function in the treated subject. So that study will include very close monitoring of the kidney function during the trial. So I think the baseline would be that the patients have to have, or the participants have to have a normal kidney function, and they will be monitored very closely during the study. Next. So the next study that we are looking into, also very exciting, is looking for impact of an antioxidants on fatigue in MS. Next. So this is, so we are doing this study looking at effect of MitoQ. It's a supplement over the counter, and it is similar to CoQ10. CoQ10, as you know, many of you know, it's a antioxidant as well, shown to decrease oxidative stress. And again, it's not like approved therapy for any disease as such, but it has a potential to change the mitochondrial function or improve the mitochondrial function. So the way the study is designed, and we are just starting the enrollment. So if anybody who's interested in this study, welcome to contact us. It will be double-blind, placebo-controlled, meaning like, you know, nobody will know, neither the doctor nor the patients will know which pill they are on, and we are testing 2 different doses of the supplement. And we are looking at primary outcome of MS fatigue, but we are also looking at the cognitive function, quality of life, and depression, and of course looking at the safety, tolerability. We'll be doing some blood tests as part of the study as well. It's a 12-week long study. So the blood test will include looking for the amount of MitoQ in the blood, as well as looking for immune markers, whether MitoQ has any impact on changing the immune biomarkers, as well as looking for oxidative stress biomarkers. So the criteria is a little bit better. It is any type of MS is welcome to join the study, and then they have to be 18 to 70 years of age, but they have to have fatigue for at least 2 months. And there are a few other criteria which I think, if you guys are interested, like, you know, please contact the coordinator. Next. So the next exciting study is looking at exercise as a mode for possible remyelination, and that's a very exciting study. Next slide. That one of our young doctors who's leading this, Dr. Nazir Willis-Croft, she is looking at exercise as a remyelination agent or remyelination therapy in MS. So it will be a longer study, 6-month study, and the subjects will be doing, sorry, can you go back? Sorry. So, so the subjects will be doing either aerobic exercise on a stationary bike or like regular, like less active. So they have to have the capacity to exercise, and then that will be done under supervision. And then the subjects have to be under the age of 65, so 18 to 65 is the age limit, and they will be, like, you know, given really very detailed instructions how to do the study, and I think a great study to take part in if you want to take part in. Next. So with a chance, again, this is randomized study, so there are 50-50 chance of being in the aerobic exercise group or just education control group. So you have to have a control group to see whether the active intervention is working. And there will be a compensation which will be available to the subjects when they complete the study. So I think most of the studies that people are taking part, they have compensation, which is very, like, you know, modest. But definitely that gives you, you know, some leverage to be able to compensate for the time that subjects give to run these studies. And so I think this is the contact for the assistant here. Next. And another exciting study looking at eyes and MS. Next. So this is a very cool study that Dr. Silverman, another junior investigator who's just starting the study, looking at this tool called optical coherence tomography angiography. So these are basically looking at an ultrasound type of tool which looks at the blood vessels in the back of the eye, and then trying to connect whether the blood flow that you're seeing through this machine does that correlate with disease activity in people with MS? So the age group for this study is to look at, to age 18 to 70. And people have to have diagnosis of MS, or they can also have this entity called clinically acidic syndrome. And they can, and their relapse should be like in the past 6 months. Okay, so I think we can move on to the next one. And she's also doing another study looking at whether the retinal vasculature, or the blood supply of the retina, can that be used as a predictor for MS neurodegeneration. So she's connecting again, looking at the people with vascular disease and seeing whether that could correlate with the changes in the eye. Next. Next. So this is a study looking at assistive device, how it can be selected. It's a physical therapy training program and looking at people who are using walking aid and if they have had falls in the last year. So trying to see whether we can optimize the use of these walking devices. And the PI for the study is Dr. Cameron. Next. And the contact information is also listed here. So Andrea is doing the study. And subjects have to have at least one fall in the last year to be able to take part in the study. Next. Next. And this study's spasticity management in MS actually is close to enrollment now. Cinda Hugo is our physical therapist. She was leading this group. So we are eagerly waiting for results of the study and like when the analysis is done. So we will keep you posted. Next. So why should we take part in research? Definitely, without our research, we will not be able to come up with the new therapies and new guidelines or new, management tools that we have been teaching. In fact, what we have learned in the last 15, 20 years has really made a big difference in our patients' life and quality of life overall. Next. Just two or three more slides on the basic science research. Again, we have a huge, and we are lucky to have very huge basic science research support and scientists who are really keen on looking at the nitty-gritty of how cells function, what are the factors which can improve or can change the functioning of individual cells, neurons, the microglia, or the myelin itself. So all of that is being done at OHSU. Next. And again, so the basic science research is also, I think, ripe for making it even better. So we have experts who are experts in myelin research. Astrocyte is another type of cell for which may have importance in MS as well. Mitochondria, of course, and then we have axonal, which is axon is the extension of your neuron, which is connecting cell to cell. That kind of research, the research which was done at the Primate Center, looking at if we can find the cause of MS, like a virus which could potentially be connected to research. So all of that resources are available and they're part of our basic science portfolio. Next. And these are the key scientists who are doing basic science research: Dr. Kelly Monk, Ben Emery, Dr. Van Vandenberg, Dr. Rooney, Dr. Faye Horak, Scanlan, and Dr. Wong. Next. I think I'll just highlight two of these scientists. Dr. Kelly Monk, she's looking into a zebrafish model and trying to understand how the myelin is formed, what are the genes which could be affecting the myelin formation or remyelination. Next. 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 Let's keep moving. Keep moving. Thank you. So this is, sorry. So this is, again, just showing that, they have detected genes within the myelin formation pathway in the zebrafish model. And the beauty of the zebrafish model is that you can actually see when the myelin is being formed from the time the zebrafish is born. So you can actually, so this is a very useful model, and it can be used to test different products, different drugs, different modalities, how it can impact the myelin formation. So having her work with us, and one of our fellows, Dr. Simpkins, is working actually with Dr. Monk to be able to take this field further. Next. And then next. And Dr. Emery is also doing research in the myelin as well. Next. And his lab is looking specifically at how the myelinating cells, which are the oligodendrocytes, they interact with the neural cells, so nerve cells during development. And they are trying to address all these questions about the formation of myelin and how can we use this information to develop strategies to promote myelination or this covering of the axon, which helps in faster conduction of the signals. So, I mean, a lot of things are happening, and there's a lot of collaboration between us and them, and we will continue to do this work as we go along. Next. So I think these are a little bit more technical, so I'm going to skip these in the interest of time. Next. I just want to thank to all the participants who take part in research, MSCs at OHSU. I think we cannot do this without your guys' support. Absolutely not. So I think I not only thank you, but I also encourage people who have not taken part in the research, be part of the movement, be part of the solution. And, we will be happy to answer more questions towards like in the Q&A session. So I think with that, I'm really a little bit kind of in a rush right now so that you can take a break. So I will just say thank you for your attention. Right now we'll take a break starting now, and then let's return in 15 minutes. So I think it's 12:20. Maybe we can come back at 12:30 or 35. So we will have the leverage. Dawn, can you come back and maybe we can confirm the timing? When should we start? Dawn?
Yes, we'll go ahead and take a quick break and come back at 12:30. So we'll end the program at 1:30. So we'll still have an hour for the Q&A. We have a lot of questions we've received, and we'll certainly try to get through all of them. We're going to try to do them kind of in the order that they're received, so we make sure to get folks' questions. I just wanted to also remind people to please take time to visit the virtual exhibitors we have, Biogen, Genentech, and Novartis. And if you were one of the handful of people that had some issues joining the meetings, it's available just during the break time. So please join during the break time, which would be now. And if you have any issues, refresh and try again. A lot of people had to go in a couple times sometimes. And
so
then,
Dawn,
yes.
Can I interrupt? So I think maybe we should give extra total 15-minute time because it can be a little bit rushed. So
Yes,
it's 12:22. So we should maybe push it further, maybe make it 12:35, definitely.
Yeah, that sounds good. So if we come back at 12:35, so you can take a break, visit the exhibitors, and come back for the Q&A panel. And speaking of the Q&A panel, next slide, please. If you have any questions after you watched any of the presentations, if you haven't already emailed me, you can email me the question at krista@ohsu.edu. Again, we'll try to get through the questions as best we can. We've received a lot of them, so thank you for that. And then if you could please go back to the previous slide. And if you have a few moments, please, again, take time to visit the virtual exhibitors. And the drawing, how that is working is the virtual exhibitors have like a keyword. And I'll just give you a hint, it's some mountains. And so different names, and you get one from each of the exhibitors. And then after the program concludes, when it's done, when we're done with the Q&A, go ahead and just email me those keywords if you went to one or if you went to all three, and your name will be entered into the drawing. And I'll be doing that actually after the program gets done. The good old-fashioned way from a jar. I'll print off all the email, all the names, and so and you'll be contacted by me a little bit later today about who won the drawings. There's a iPad, iPods, the earbuds, and then some OHSU mugs. So hopefully everyone will have fun, and we will look forward to seeing you when we come back at about 12:35 for the Q&A. Thank you.
Hello, everyone. I think we are live now. Cool. Thanks, Josh. Sorry, thanks, Joe. So Dawn, do we, we'll just leave this slide right here. Okay. All right, good. So welcome back, our speakers. I'm the moderator here, Vijay Yadav, and then our speakers, Dr. Spain, Dr. Evans, and Dr. Pierce. And we have tons and tons of questions, so I'm trying to go through them as fast as I can. And Dawn, if I miss anything, feel free to like hop in and just remind me if we missed anything. So I think there are tons of questions for all of the panel members. So, but I think since COVID is such a hot topic, I'm going to start with that. And before COVID, there's one more question which is somewhat related to the Ocrevus and vaccine. So I think I'll just start, Dr. Evans, with you. And this is about the herpes vaccine.
Dr. Yadav, can I just
Yes.
interrupt you for just
Yeah.
a moment?
Sure.
Kenneth, can you stop sharing the Q&A panel? So Dr. Spain's going to be available, Dr. Evans, and Dr. Pierce, and then Dr. Yadav's going to be moderating. This way people can see you guys. Thank you.
All right. Thanks, Dawn. So feel free to interrupt like Dawn or Joel or Ken if there's any technical issue, because I think this whole virtual meeting is like a little bit of a challenge, or can be a challenge for all of us. So please be patient with us, and please be forgiving as well. So all right. So Dr. Evans, the question is when to get the herpes vaccine, the Shingrix vaccine, while on Ocrevus. So what's the best timing? Do you have any thought on that? Otherwise, I can also talk on like what we are recommending. Can you unmute yourself?
Sorry, I can tell you this is like modern technology. Again, the further away that you can sort of, wait to give vaccines from sort of immunosuppression, of course, the better response. I don't know specifically, Dr. Yadav, I'm going to defer to you, sort of what you guys have been having conversation for your MS patients. So maybe I'll actually defer back to you specifically for that question.
No worries. So I think what we are doing is most vaccines, they should be given at least 12 weeks after Ocrevus dose is given. If somebody is already on Ocrevus, then wait at least 12 weeks after the dose is given. If the dose is due, for example, you are approaching the 6th-month dose, try to get the Shingrix vaccine at least 2 weeks prior to the dose. Okay, so I think that's how we are recommending. That's the National and MS Society's recommendation as well. All right, so I think the next question will be any feedback on how the immune modulators are affecting the expected immune response with the COVID-19 vaccination, and is the protection minimal or non-existent after the vaccine? So I think any of you can take.
Who wants to take this? I'll take this one. I guess all things COVID. I think that we know that. First of all, we don't know what sort of durability looks like for these vaccines. These vaccines are still new. So far, it seems that, if you have a normally functioning immune system that, 6-7 months after the vaccine, people still have neutralizing antibodies. As more time goes along, we'll have more data to submit. I mean, they're still monitoring the folks in the phase who were in the original clinical trials. And so their data will probably come first before, we'll have data for sort of the general public, and that will sort of guide sort of recommendations around sort of the durability for the vaccine. As far as response rates to the vaccine, I think there's just so many factors that go into that, whether or not you're an immunomodulating therapy. Age for vaccine responses may be very different. We know that our younger folks just have a more robust immune system. I think sometimes, as I said in a previous slide, that the measurement of sort of antibodies may not necessarily be reflective of your ability to actually mount a response, because what you're looking for, again, is neutralizing antibodies. And there's just so many parts of the immune system, your B cells, your T cells. And so, just looking at just the humoral response may not necessarily be reflective of your ability to kind of respond to the vaccine. So I don't know if that was okay. If anyone else wants to, and Dr. Spain talked about also immunomodulators. So if anyone else wants to add.
Well, I think we have the clearest data on B-cell therapies and fingolimod that they inhibit the ability to mount as much of an immune response to the vaccines. But as far as we're aware, and again, the data are still coming out, for the vast majority of the other disease-modifying therapies, the immune response is the same as if you were not on those disease-modifying therapies. So a good response, same as the general public. And so that's why the MS Society and we encourage everyone to get the vaccine. And even if you are on a B-cell therapy or fingolimod, we still say get the vaccine. It doesn't hurt to get the vaccine, and you may be getting at least partial immunity.
Thank you. So another question related is that one person says, I've been getting vaccine, not the vaccine, I've been getting the Ocrevus infusion every 6 months for about 3 years. I also received the COVID vaccine. With Ocrevus destroying my B cells, how effective is the vaccine? So I think it's sort of tied to the same question that we were just discussing. Get the vaccine. Yes, B cells are affected and they are killed by the Ocrevus, but B cell response is not the only response that the vaccine is generating. So I think because there are other immune cells which are generating response to the vaccine, to the virus. So vaccination is really critical. So please get it. The next question is, how does, I think it's about hepatitis A or B, affect an MS person who decides to go with an infusion DMT? Becca, do you want to take that? Hepatitis.
Essentially, as far as I'm aware, the B-cell therapies are associated with the risk of reacting latent hepatitis B. And so we do check before we start people on a B-cell therapy. So that's rituximab, ocrelizumab, or Ocrevus, and Kesimpta, or ofatumumab. We check whether or not you've ever had hepatitis B. If you haven't had hepatitis B, it's not like you need the vaccine series. It's not necessary because being on the therapy doesn't increase your risk for getting hepatitis B. But if you've had hepatitis B and it's in a chronic latent state, we would treat you for both hepatitis B so it doesn't reactivate and cause a problem when you're on the B-cell therapy. Did I make that clear? It's a little tricky, right. But there's sort of 3 categories. If you're immune to hepatitis B, and we tell that with some blood tests, you're fine. If you've never had hepatitis B, you're also fine. If you're in this category where you've had it before and it's kind of in a low chronic state, you need treatment for the hepatitis B along with your B-cell therapy. As far as hepatitis A and B for any of the other immune modulating therapies, I don't believe there's any concern there. Do you want to add?
I was just going to add. I was going to say that, I mean, and I completely agree with Dr. Spain. I mean, I think it really depends on your exposure risk. I mean, hepatitis E is something that we see more in developing countries, even though we did have our outbreak in Portland like 2 years ago at one of the restaurants in the Southeast. So, you know, it's, again, a foodborne illness. You know, I always feel an ounce of prevention is worth a pound of cure. So, you know, why not get the vaccine if you have the chance to? You know, even though you may not necessarily mount the most robust immune system, you know, you still will have something. And I agree with Dr. Spain. I mean, I think that, you know, exposure to hepatitis B is rare. I mean, there are risks in terms of blood exposure and so forth if you work in healthcare and so forth, but or if you're on dialysis or something. But I think for the majority of the public, it's probably not a very prevalent disease we see here in the United States. And of course, you fall in 3 buckets, whether or not you're immune and you're good, you have antibodies, or you've had previous exposure and your immune system is kind of suppressing things, and you know, whether or not, again, sort of depleting that sort of immunity can sort of have reactivation is always the risk, as Dr. Spain said. So
thank you. So another question that is asked is, let's see, is it possible to get a 3rd dose of vaccine? Like, you know, if you don't really have the antibody response after being vaccinated, especially on a DMT like fingolimod or B-cell. So should people get a 3rd dose? And is there any downside to, like, you know, doing that, or plus, can you combine the 2 vaccines? So I think not just 2, but like the 3 vaccines which are available. So can you do combinations? So.
Maybe I'll take this one. I do vaccine clinic tomorrow, so these questions come up. So these are great questions. So we do revaccinate folks for lack of immunity to a vaccine, like we do for your Hep A series or your Hep B series and so forth. We just don't have enough data yet around the COVID vaccines. I think it really has been practitioner dependent about whether or not people will get sort of recommendation of getting that sort of revaccination series. There's no official recommendation. And so I have not been recommending that as just, part and parcel to looking at quote unquote immunity, because again, we just so much about the immune system post-vaccine that we're just not aware of. And there's no FDA recommendation to keep on revaccinating people until we get some level of, of immunity or measurable immunity. It's just that you've gotten your vaccine and this is, and we may come to a time where we change our tune around this once we have more data available.
No, I agree. And how about the combining the vaccines?
Also a good question. So I just had someone the other day who got the AstraZeneca vaccine and came in and they no longer, I think it was they got their AstraZeneca vaccine in Mexico and then they came here and they needed to get a vaccine and the AstraZeneca vaccine is 2-dose series, so they're missing the 2nd dose. And we just went ahead and gave them their series of they actually got the mRNA vaccine. So there's just again, we're still building the plan and flying it at the same time about mixing these vaccines. But I think the premise for every recommendation is complete the series. So if you've gotten something and you've missed the 2nd dose, I don't think, just from my gut feeling, that there'll be any issue, but the series, you're still considered partially immune if you have not completed a 2-dose series of what should be a 2-dose vaccine.
Chris, another related question was, is there advantage of getting a 3rd dose of a different vaccine, so that you are getting basically double protected or triple protected? So what's your take on that?
Again, I feel so bad saying that we just don't know. We don't. We don't know if changing before getting a adenovirus vaccine and now you're getting an mRNA vaccine in any way stimulates the immune system any differently. We think, of course, that the mechanisms are all the same, except that the mRNA vaccines don't necessarily go into sort of they don't transmit viral material. They don't transmit material specifically for your polymerase to make and nucleus and so forth. And so I think at the end of the day, we just don't know whether or not mixing vaccines or giving certain groups of folks mRNA versus the adenovirus vaccine in any way stimulates a better immune response. And I think that's why the MS Society came up with the recommendation that you should just get whatever vaccines available until we have the data available.
Another question related to the Ocrevus is being on Ocrevus or any B-cell depleter therapy with 2 comorbidities, does it increase the chance of death with COVID by 4.5 times? So I think maybe I can take that question. So right now, I think the data is still limited, even though we had this database coming out of mostly the US MS centers and MS doctors who that was just published earlier this, I think it was June of this, we are in June, so this month. But the data basically is not as clear. Rituxan is only therapy among all of them that shows to have higher risk of any kind of either higher morbidity or possible mortality. But it's also not mortality, it's more hospitalizations. So I think we should really take it with a grain of salt and not really. The good thing is we are able to control the ones who is vaccinated. I think we are able to control the severity of COVID quite effectively. So hence, I think these numbers, even though they are published, I think they may not be as relevant now or maybe in the future. So would you agree, Dr. Evans?
I completely agree with you. I mean, yeah. Yeah.
So I think what the data was 6 months ago may not be relevant now because now we are looking at the population which is post-vaccination. So I think we will have better numbers now versus 6 months ago. So I think we should really keep that in mind. The data is changing rapidly. So even though, what is published today was like, 8 months ago, it may not be as relevant. So just keep that in mind.
Yeah, I think the best kind of paper was that sort of looked at this was more, I guess, the outcomes in the I think it was Salter in
Yeah.
the JAMA in neurology.
Yeah.
That's probably the biggest paper I think that's come out, just looking at
Mhm.
outcomes in MS patients. But we don't have a lot of data yet around outcomes in MS patients post-vaccine in terms of severity of illness and so forth. That's just still too new.
And I think there was another question about the timing of the vaccines. Just to clarify, in general, for the B cell therapy, especially Ocrevus and rituximab, we are advising people to wait for 12 weeks after the vaccination is done to be able to receiving the COVID vaccine, and if you are due for the next dose, then get the vaccine at least 4 weeks prior to the infusion. So I think there were a lot of questions on that. So I just want to re-emphasize that. And National MS Society actually gives a very nice guidelines. So if you want something in writing, please go and visit their website too. All right, so I think we will let's see where we are. So I think this question will be for Dr. Spain. Is there a blood test available for a marker that can help determine if somebody has progressed to secondary progressive?
Boy, I wish there were. No, we don't have a specific blood test or a specific MRI that can really tell us if someone is has changed from relapsing to progressive MS. It's a clinical diagnosis, so it's kind of one of those you look back and say, gosh, what could I do a year ago that I can't do now? And is that because I had a relapse where I didn't recover, or has it just been a little slow, gradual worsening? And another thing to figure, is it a slow, gradual worsening because I have arthritis or I have other conditions that may make my function worse, or is it really all MS related? And an MRI can help support that, but there is no one specific test. It's a challenge.
Absolutely agree. Another question is about whether or not one should stop the disease-modifying therapy. So, for example, this is a 57-year-old female who has been on Copaxone for almost diagnosis like 20 years prior, and then does not really have relapses anymore, but the main symptoms are cognitive decline and fatigue, and other symptoms are manageable. But lipoatrophy, which is a known adverse effect of Copaxone, is a problem, and it's challenging to continue using Copaxone. She would like to reduce her dosage. So is that a reasonable approach, and should we stop it altogether? So Dr. Spain.
Well, yeah, that is the $100 million question, $60,000 question, whatever that is. So I would say we don't have guidance yet, but that guidance is coming soon. So there is a multi-site trial through the NIH that is asking the question, what happens in people in exactly your situation when you stop disease-modifying therapy? And so people in this trial either stop their therapy or they continue their therapy, and they're closely monitored. So with clinical exams, with MRIs, and we're going to see whether or not it was really a safe thing to do in terms of stopping that therapy. What do you do until that study result is out? So I would say this is a great discussion to have with your MS provider. And different MS providers are going to have different attitudes toward this. You could say, is it hurting anything? Why not keep taking it? Or you could say, is it helping anything? Why keep taking it? And both attitudes or both stances both arguments have their merits. So I think this is a great conversation to have with your provider and figure out what works for you, your provider, your tolerance to risk. There are, and I will say just personally, what I have done with some people who are in this situation is we do a baseline MRI, stop the drug, and a year later get another MRI, do a neurologic exam, and kind of sort of see how things are going. Some people say, I feel just the same. I guess I didn't need it. Some people say, I don't feel good. I feel worse, or we see a new lesion on the MRI. We resume the medication. So that's been how I've been handling it on a case-by-case basis. But I will say, well, I will feel much more secure in offering advice once we have the results from this clinical trial, which maybe Dr. Yadav, you know when the preliminary results will be out?
So we are actually ready to close the data. So I think in another, maybe end of this year, we may have some preliminary information.
That's
Study will-
fantastic. I can't wait.
Yep. Yeah. I think the plan is to really try to present at the ECTRIMS meeting, which is in October of this year. So hopefully there's a big rush to analyze the data. So stay tuned. All right. So Dr. Pierce, question is, how do you know if your cognitive decline is associated with MS or some other short-term memory disorder?
Great question, and that is very challenging. And I think that first stop is to speak with your MS provider about it. And I think that with some amount of discussion of the symptoms, some cognitive testing, review of your imaging, that can help to make that determination. But it can be a challenge, and sometimes you may end up seeing a cognitive neurologist like me in addition, or doing neuropsychological testing, or doing even further diagnostic testing, like I had referred to, like not just an MRI, but maybe a PET scan or maybe a lumbar puncture to get to the bottom of it. But I think that oftentimes, if your cognitive symptoms are those that can be most typical of being related to MS, like difficulty with attention, processing speed, executive function, and the MRI is most consistent with MS and not showing other specific forms of atrophy, then most likely it is related to MS, and working on treating the MS and all of the associated lifestyle factors can be helpful.
So another question for you, Dr. Pierce, is, can a person living with MS seeking to improve brain health benefit from using a linker bike and other devices, and what are the resources available for people to seek?
Which bike did you say?
I did not know about this. It's like the spelling is a linker, but I'm not sure if there's a special bike or but it is. I'm assuming it's kind of like stationary bike or.
So what I would say, I think that again, first stop speaking with your MS provider is really important. But it was just really neat for me to hear Dr. Spain's talk and to hear that focus on lifestyle interventions and all the research going on in the MS group with physical exercise. And that is often what we recommend for prevention of Alzheimer's as well. Number one is physical exercise during midlife and elderly years. And then in terms of the type of physical exercise, at least for Alzheimer's prevention, we generally recommend aerobic exercise, which can be done, stationary cycle, regular cycle, brisk walking, any of the forms. And for Alzheimer's prevention, it's not clear that a specific form is beneficial for prevention, but the goal is to do cardiovascular type exercise. And then the other aspects of exercise, I always say there's physical exercise as well as cognitive exercise. And so, and sometimes the question comes up, well, what type of cognitive exercise? Should I sign up for Lumosity? Should I play brain games on my phone? And I would say that there is not evidence that a specific form of cognitive exercise is more beneficial than the other in dementia prevention. But I think it's important to do it regularly on a daily basis. I encourage my patients to get daily cognitive exercise for at least 20 to 30 minutes or more, and make sure it's a variety of tasks. So not just the same thing every day. And so sometimes these computer programs are nice because they do change it up. But I think that it's better to find something that you like, that is provides some variety, and you don't keep doing the same thing.
So another question related to the treatment was, is taking fish oil a good surrogate for actual fish consumption? And if so, how much is recommended?
So I think that at least for, actually, I don't know. Who was that one directed to?
I think I just assumed it because it's cognition.
I was glad you were taking that aim, Dr. Pierce.
Well, I can start. So what I would say is that it's not known. And I think that the epidemiologic studies were really about fish consumption rather than fish oil. That showed that there was some association with reduced Alzheimer's risk with number of portions of fish per week. And so I think that in general, though, there is reason to think that fish oil supplements may be better than nothing if you're not able to get your fish in. But in terms of dosage, it's not that's not been determined yet.
Let's see. There's so many questions. I will just try to figure out, like, which one should I ask right now? Maybe I should switch the gears. Okay. I think I'll come back to Dr. Evans again, but let me just ask some, non-vaccine or non-COVID question right now. So I think Dr. Spain, the lipoic acid. So is lipoic acid contraindicated in certain circumstances?
Well, that's a great question because, as you may know, over-the-counter supplements really have very little oversight by the FDA. So the FDA has some guidelines on manufacturing supplements, and so a quality over-the-counter supplement will have a stamp on it saying good manufacturing practices or GMP. But that purely says that it was manufactured in a quality way. It doesn't say at all that it is safe to take. And so sometimes what we find out through trials, large trials that are looking at supplements that are really available over the counter is that there are risks that we didn't really know about them. And so I will say that we have found that some people taking the lipoic acid in our clinical trials have developed some reversible kidney problems that shows up as a change in the urine, a urine test called looking for urine protein. And so I would say lipoic acid is not good for anybody who has kidney problems. And we don't allow people with kidney problems in our clinical trial. But anybody who's taking any kind of supplements or medications really should let their doctors know that they're taking these medications and, get some routine screening lab tests regularly, which I think most doctors do, most primary care doctors do, to just make sure that the kidneys, the liver, the blood count are all doing okay, even taking all of these medications, including supplements.
Becca, I think a related question was also the recommended dose, and are there some brands which are safer than the others, and what should they look for? So I think we can maybe wrap it up here.
Oh boy, I get this one a lot. So I will tell you the dose that we're using in the trial is 1,200 milligrams. So that's 1,200 milligrams. It gets a little more nuanced than that. So when you go to the store to buy lipoic acid, it comes in two forms. It comes in a racemic form or the R form. And so we are using the racemic form. It's usually the cheaper form. So that would be 1,200 milligrams. If you were going to take the R form of lipoic acid, an equivalent R form would be 600 milligrams. And there is some reason to think that the 600 milligram R form may be preferable in terms of stomach upset and how well it gets into the system. However, we started our clinical trial with the other form, and so we're using it to the end. So I would say it's 1,200 milligrams of the racemic and confusingly labeled 600 milligrams of the R form of lipoic acid. What is the difference between the two? Look, actually, lipoic acid is naturally occurring in our bodies, and it's naturally occurring in small amounts in foods that we eat. And the kind that occurs naturally is the R form. But when you manufacture lipoic acid, it comes out in two different shapes, an R form and an S form. And if you can remember back to high school chemistry, sometimes the same chemical formula can have two different three-dimensional shapes. And so the R form is one shape and the S form is the other shape. If you have all of them together in a mixture, it's the racemic. And so that's why it's sort of a double dose of the R form. The other question as to whether or not I have a preferred brand. I don't have a preferred brand. We get some lipoic acid donated by companies for our studies, but I would say any company that uses that good manufacturing products, that GMP stamp, is a quality product, and that's probably about as good as I can recommend for taking it. Again, if you start taking it or are taking it, make sure your MS provider or your primary care doctor just screens your blood and screens your urine for just routine check to make sure that you're doing okay on it.
Thank you.
Or join the clinical trial, and then we'll know if it actually works and you should be taking it or not.
All right. So Dr. Pierce, one question is, how do you determine if cognitive decline is caused by the CTE, which I understand chronic traumatic encephalopathy, or versus other causes? So that head trauma and cognition and MS.
Great question. And so, yes, CTE, chronic traumatic encephalopathy, has been in the news and is of high concern. And this is associated, this is dementia that develops many years after head injuries, especially concussions and even subconcussive blows to the head. So often described in football players, boxers, veterans who've been exposed to blast injuries, and even other sports as well. And so I think that CTE at this time is made on pathologic diagnosis only. And so that means it can be identified in the brain at autopsy. And with CTE, it's very interesting. The findings, examination of the brain, are tau tangles. And so these tau tangles are seen in Alzheimer's disease as well. But with CTE, the tau tangles are in a different place in the brain. So in Alzheimer's, the tau tangles form in the hippocampus, the temporal lobes on the side, important for memory. And in CTE, the tau tangles tend to form more at the frontal lobes as well as the base of the brain. And so with CTE, there tends to be a lot more personality change rather than direct memory impairment. So as far as diagnosing CTE while someone is still alive versus Alzheimer's or another form of dementia, right now there are studies looking at new imaging techniques like tau PET scans or tau blood tests, variety of other things, but there's no diagnostic test that can help or prove that someone has CTE while they're still alive, and it's based on clinical assessment. So again, just a very detailed history, neurologic exam, cognitive testing, but it really demonstrates the fact that we need to understand more about CTE.
Mm-hmm. Thank you. So Dr. Evans, another question is steroids and COVID. So should steroid be discouraged during COVID even if vaccinated? Can you
unmute? Steroids before you?
It's not clear, but maybe I think you can talk about the use of steroids during COVID, like as a COVID infection treatment, or like the side effects, something like that.
Definitely. So right now, sort of the principles of therapy for severe COVID are treatment with medication called remdesivir and steroids in people who are hospitalized with COVID. And I think that's really important. So not if you have COVID and you have no symptoms or you have very mild symptoms. The benefits for starting steroids were really seen in people who were on sort of oxygen supplementation. So basically, if you are diagnosed with COVID, your doctor, there's no benefit to just putting you on steroid just because you have a COVID infection. And so So typically I would not recommend anyone start on steroids, just because they have a COVID infection. The second part is, I guess I brought up my slides is around giving steroids, vaccines. We know that, anything that blunts the immune system's response to sort of stimulation. So in that case, the vaccine it's not going to be good long term. And so, hopefully we always ask folks if they are on steroids that if they have the luxury to wait at least 3 to 5 days before they get their vaccine. So to kind of give that sort of washout period, and hopefully not blunt your immune response. It's the same reason why we typically don't recommend people take Motrin or Tylenol before they get their COVID vaccine, because again, we really want you to have that robust immune system. Now, if you have a little bit of arm soreness after that, then it's okay to take your Motrin or Tylenol, but not before.
Could I add just a point to that? I would direct people to the National MS Society website. They have done an amazing job at putting together expert recommendations for taking disease-modifying therapies. They also have a section in there about whether or not you need high-dose steroids for an MS relapse in relationship to COVID, the vaccine. And so there's a section in there to review as well if that was anybody's concern.
Thanks. So I think this is a question maybe, Becca, you can take. So since DMTs have a mild to moderate effect on cognition, should patient or MS patient over 60 remain on a DMT? I think it was maybe somewhat connected to the previous question, but yeah.
Yeah, that's a great question. And if you remember, I showed a picture of how what did we call an effective treatment, and it was very based on that physical ability. Can you walk or not? And is that the right outcome? Are we looking at things like cognition and how well are these therapies helping cognition or maintaining cognition? And what is the effect of aging in all of that as well? And so I hate to do it, but we don't have great data on this question yet. And I assume, and Dr. Yadav, maybe you have, since you're closer tied to the study on stopping disease-modifying therapy, some of the outcomes that they'll look at in people who stop the therapy versus people who continue the therapy are cognitive outcomes. And then we'll get some information from that study to tell us whether or not it made a difference on cognition in the people who continued the therapy versus stopping the therapy. But I think I would say that it's been only more recently that we did more detailed cognitive testing as part of our clinical trials of therapies to really understand the effect of MS of these disease-modifying therapies on cognition. So stay tuned, but I think we're going to get some more information from that soon. I guess that would argue stay on your therapy until you get that information.
And, related to that are many questions like, if it's an elderly person who should be starting disease-modifying therapy. So I think maybe I'll just say those questions and we can try to address everything together. So one question was, is there any health benefit in starting using any oral infusion, oral/infusion DMT at age 60? Or is there DMT appropriate for patients who are above 65 and have stable MS, and specifically about MASN because of the effect on the SPMS, so non-active. So maybe we can try to wrap up that as well right here. So aging and DMT.
Yeah. MS looks different in different people, and you all know that more than anybody else. And some people have very active disease early in their disease course. Some people aren't even diagnosed until their 50s or even later. I think the oldest person that I have diagnosed with MS, new onset MS, was 72. So, it's a bell curve of when most people are diagnosed and when they have the majority of their disease activity, but there certainly are unique situations and individual cases. So there isn't sort of one rule, and there isn't a hard and fast cutoff at 60 or cutoff at 65 that a drug is going to work or a drug is not going to work. But there's general patterns that we can see. And so I think when somebody gets to 60 or 65 and the general pattern for that person has been, they've been slowly progressing, but without any active disease, meaning a clinical relapse or a new MRI lesion, or somebody's been very stable. They haven't been worsening, but they haven't been relapsing either. Those are the people when it's time to start considering, do you still need to take this medication? And again, this study is going to really help us guide us as providers, guide patients as to what to do. But if there is active disease and there's concern that there's inflammatory activity that can be effectively treated with the medications, it is certainly indicated regardless of the age. As we age, our immune system does decrease. People do get more prone to infections. And so I've certainly had the situation where people have been taking a therapy, particularly for primary progressive MS, where it's sort of it's really hard to tell when to stop taking a therapy, where they start getting repeated infections. And I'm concerned in older people or more disabled people. And so if they start getting repeated infections, I'm concerned that their therapy is weakening their immune system to the point where they're at risk for infections. And that's a reason to stop therapy as well. The risks are getting too much for that benefit of the therapy. So right now it's still all an individualized game in terms of deciding whether or not to continue therapy. Now, if you haven't been on therapy ever, say you were diagnosed way back in the day when we didn't have any therapies, now we do have a lot of therapies. Is there a health benefit of starting a therapy, if you're in your 60s or later? And again, if you don't have active disease, likely the answer is no at this point. Until we get some great therapies that repair your immune system, that are neuroprotective, that remyelinate. So that's where the research is pushing to help this group of people who maybe don't need their immune system tinkered with, but do need to repair and regenerate.
Thanks, Becca. So I think there are a couple of questions about the ophthalmology aspect of MS. So I'm just going to take those. One is who is at OHSU or elsewhere who deals with ophthalmology and MS especially. And so it looks like I think resources for eye exam or good eye exam and eye evaluation. So OHSU definitely is a resource. The one thing to remember is a general ophthalmologist. Optometrists and ophthalmology are two different specialties that deal with eye. Optometrists usually will be looking at your refraction, like, the glasses that you need for, as you age, the vision will change or otherwise. So those are refraction, but we recommend people to be seen by ophthalmologists who are doctors who do the eye exam in detail. And then, for example, there's a test, this OCT test that we were talking about, that can be done by ophthalmology. And then the sort of inference or like the recommendation from that can be given to the patients about what the OCT numbers look like. There is some data that if you do this OCT test, you can look at the thinning of the back of the eye, and that can predict how the visual recovery could be, or there's some connection between MS brain atrophy and the back of the eye thinning as well. So there is some, but these are mostly in the research versus the clinical practice, but that could be something that one can ask the doctors. So ophthalmology is the right one to do, but a general ophthalmology, a good general ophthalmology would be a very good person to start with. Neuro-ophthalmology, as I said, are special. Either they are ophthalmologists who are specialized in neurological diseases of the eye, or neurologists who have specialized in eye disorders affected by the nervous system. So both of them are usually utilized for very complex cases, and there are very few of them in the state. At least we have Dr. Julie Falado. We used to have Dr. Bill Hills, and we had Dr. Egan. So three of them are the ones that I know of who are in town. But it is hard to get to see them just because of the number of patients that they see. So general good ophthalmology would be fine. We have tons of good clinical practices across the town and the state. So I think that's a good place to start, and come to HSU also for any any special needs after that. And the other question was about the inflammation or eye inflammation without pain when you have blurred vision in eye triggered by stress, which is continued despite taking Ocrevus in a non-ambulatory individual. So can steroid be used in this situation to treat the vision loss, risk, or other like an inflammation? I'm assuming like inflammation of the eye. So not every blurred vision is because of inflammation. That's something to really keep in mind. So steroid should be used very carefully for any condition, whether it is for systemic inflammation or for eye. It should be used very carefully and under the supervision of a doctor like ophthalmologist or neurologist. And typically, people who are on Ocrevus, they do not really have ongoing disease activity or inflammation. Like it's very very well controlled, except for probably less than 5% of the people on Ocrevus may have disease activity. So, but that should be evaluated and see if what other effective therapy can be used. It is safe to use steroids in conjunction with Ocrevus, but only on a limited basis, not on a regular basis. Okay, so I think that again should be addressed by your neurologist as well as ophthalmologist. So the bottom line is do not use steroid unnecessarily because it can harm as well. Okay. All right. So the next question would be about cannabis. When will cannabis-based medicine such as Sativex become a primary medicine? So, Becca, you can take that.
Is the question when will Sativex be approved?
Yeah, become available for as MS as a primary medicine or like as is one of the big use medicines.
Yeah. So there's a pharmaceutical company, GW, that is starting up a trial to evaluate Sativex for spasticity. It's literally just starting up. So I can't imagine it's going to be available as an FDA-approved product for, I don't know, 3 or 4 years at least at a minimum. But it's on its way in terms of investigation, and it's a really important investigation to do in a carefully controlled randomized trial because for one, we need to know, does it actually really work on spasticity? But two, we really need to know about side effects and risks of it, and particularly in an MS population. Does it have cognitive effects? Can it make balance worse? Are people at more risk for falls? And so this needs to be carefully studied in a clinical trial. So if we are an enrolling site for that study, I would encourage you to participate in that trial. I believe you would only need a 30-day washout if you're already a current user of medical marijuana. And again, if you can sign up for our research repository and put your name on our list, then we can call you when these studies become available.
So I think we are sort of running on time. I'm not sure, Dawn. We have many more questions to go through, so I do not know what's our timeline. Can we keep on going, or can you guide us on that?
Yeah. So we were going to go ahead and go until 1:30 if that works for you guys.
Sure. Okay. All right. So I think I'll keep going. I'll try to address as many more as I can.
Thank you.
So Dr. Evans, the question was, a 31-year-old healthy person is refusing to get a vaccine because she's concerned that she'll get blood clot from J&J or myocarditis from the mRNA vaccine. So how should a parent handle that?
I said 31. Was it 31?
So the patient herself, patient's daughter has she's refusing to get the vaccine because of the safety concerns. So how does she convince her to get it?
Yeah. So the first thing I'll start first with blood clots. COVID causes blood clots, and so that's usually one of those things I mentioned to patients is that the sequelae of a COVID infection is really bad. And even if people get mild symptoms, there's a long sort of now research around even long COVID for people who've had mild symptoms, where it's cognitive issues, just kind of chronic fatigue. I mean, some of the things that both Dr. Pierce and Dr. Swain talked about, so just worsening of just mental faculties and so forth. For the J&J vaccine, it's such a rare occurrence. I think that, we do many things in our daily activities that, have a much higher risk of poor outcomes getting to your car and driving, as compared to the risk of a clot from the J&J vaccine. I'll also add to that. This was seen in women of childbearing age. So, of course, if this person's daughter is in between in that risk category. The second thing is for the mRNA vaccines, and specifically for the Pfizer vaccine, this is the myocarditis and pericarditis is still a signal that people are looking at. They're not 100% sure, but so far it's only been seen in young adolescent men. So again, it doesn't sound like this person's daughter would be in this risk category for as far as we know from the data we have so far around this, and millions and millions and millions of people have gotten the Moderna and the Pfizer vaccine without having any of these risks. I mean, a lot of times with clinical trials, of course, we know is that, you have 30,000, 40,000 people participating, and they're just things that we'll just never see just because the volume is not there to see some of the minute signals that pop up when vaccinate larger populations of people. But I think universally, I think all of us would agree that the benefits of whatever vaccine you can get would, or recommend to your daughter, benefits outweigh the risks. And the last part I would say is that if this person is immunocompromised, this is also about protecting community. So, if her daughter is young and healthy, I feel like if she's not doing it for herself, she should do it for her family, because there may be people in her circle that for different reasons may not be able to get a vaccine. And so by getting a vaccine and hopefully protecting herself from getting COVID, she prevents transmission to others.
Thank you. So I think we only have 4 minutes left. So I think I want to be really, be careful about the timing here.
Speed round.
Trying to do that, but it's just hard to reach through and do back and forth. Okay, Don. So please, have patience with me. All right. So I think another question about muscle weakening, and can that be rebuilt in MS? Like if the muscles are weak, and what kind of exercise should be recommended, like aerobic exercise, especially with people who have mobility issues. So, Becca, you want to take on that?
Absolutely, muscle size can be increased. I think a combination. Studies generally show that combinations of aerobic and resistance, like with some light weights, are effective at doing that. I actually ran a very small trial of aerobic exercise. I didn't do the weight, but it was aerobic exercise. It was 8 weeks, and I had people after 8 weeks say, "Oh my gosh, I don't need to use my cane anymore to walk." It was really quite impressive. And these kind of gains can be made in people doing seated exercises as well as standing exercises. So exercise improves everybody at every level. There are recommendations, again, on the National MS Society website, along with links to videos for both seated and standing exercises that you can do.
Thank you. So I think there's a question from a veteran who says, who's asking, can vapors, water, burn pit contamination contribute to MS? So any thought on that?
You're going to have to repeat. Can what?
So can vapors, I think it's maybe some kind of environmental toxin vapors, I'm thinking, and burn pit contamination. So basically use of any kind of environmental, pollutants, can that contribute to MS?
Yeah, that's a great question, and in some ways the VA is a great place to study these, because we have a national database of veterans enrolled in the VA. Right now, there haven't been any studies that have shown those associations, but that doesn't mean there won't be. But as of right now, we don't have we don't have that that knowledge. If you're a veteran, right now, if you've been diagnosed with MS within 7 years of your military service, that's how you get service connected for your MS, not based on any kind of exposure at this point. Since we're talking about the VA, I just will mention that we have an excellent neuro-ophthalmologist at the Portland VA as well. So that's a resource for veterans.
Thank you. So I'll take a few more questions here. One is the question on C-reactive protein, and is it normal for people or MS people to have high sensitivity C-reactive protein, and what is the relationship of this number and how one might react to the COVID vaccine? So Chris, any thoughts on that? So C-reactive protein elevated and like vaccine and basically systemic inflammation and
That I'm not sure of because it's not something that we're routinely measuring sort of post-vaccination. We know that C-reactive protein is, we use it for measure of inflammation, but don't have much information around its relationship to the COVID vaccine. Sorry.
And I can only chime in about, like, at least for MS, there's typically, by MS itself, we do not really have high C-reactive protein, but if you have systemic inflammation due to some other cause, I mean, as simple as like even heart disease, you can have high C-reactive protein. If you have some kind of infection, inflammation, which is non-MS, can cause high C-reactive protein. So use that as a systemic marker of inflammation versus, MS specific. Right, I don't think so that could be a contraindication for the COVID vaccine per se, because I think we are giving COVID vaccine to pretty much all diseases, including vascular diseases. So I think we should not, at least for the time being, we don't really have a specific justification for not doing that. A couple of questions about discovery in Dr. Scannon's lab about remyelination thyroid hormone. So the studies that were done were mostly done in the mice, which was very promising, and the adult trials have not started yet, to my knowledge. It has been funded nicely by some, I think, external companies, so that probably will happen sometime in California or but I do not really have the exact timeline of where the study is right now. Then one question on Tisabri. Somebody has been on, a 56-year-old has been on Tisabri for almost 13 years, done extremely well. How long should they be on therapy? Becca, you want to take that?
Yeah, that's kind of a tougher one. Because Tisabri is such an effective therapy, you don't know whether it's just really doing its job super well or whether it's actually not necessary to be taking anymore. And so because there can be a risk of MS rebound with some medications, and Tisabri is one of them, if there is the thought of trying some time off of it, and this would be a situation where you would switch to another therapy that doesn't have that risk of rebound, and see kind of a de-escalation process rather than an escalation process. So switch to maybe a less effective therapy and see how you do that with that one before doing a trial off, if that's the decision. But again, we don't have the guidance yet. And so that would be my approach if that was this decision made to do a trial off.
So one comment on Kesimpta, I would just say, there was a question on Kesimpta, that's why I'm giving this comment. Kesimpta is equal, I would say equal in efficacy to B-cell depleters. So it's in the same category as B-cell depleters. So Ocrevus, Rituxan will be in the same category. And then distinguishing mild MS from MS, which is effectively treated. I think if MS, which is majority of the people is relapsing MS, at least in the younger years, should be treated continuously. You should not assume that it will go away because we don't really have a cure yet for MS. I think DMTs control the disease, but they don't take the disease away. So be careful about that and discuss with your doctors. Do not really just do things on your own. And read the
Can
research
I put
into.
a plug in for
Sure.
the study that is seeing how well people do if they stop their therapy? You have to be at least 55 years old to even be in that study. So again, early treatment and continual treatment is effective treatment for MS.
And thanks, Becca. I think we are really, really behind right now. And I just want to just try to address everything possible. So research into what causes the immune system to attack our own bodies. It is like a huge, huge topic. And like, I think the work has been going on for decades. It will continue. So we won't really have, any definitive answer for a long time. But at the same time, because we have 20+ therapies for MS now, think about it in like last 20 years, we will be seeing a huge boom in this field. So I'm very hopeful that immune disease will be controlling very effectively going forward. So I think with that, I would just wrap up. And then one more last comment was people who are on B-cell depleter therapy, how should they protect themselves and others? So I would say for the time being, since there are a lot of confusion on like how much efficacy is there, just continue using the same precautions, mask and everything that was given before vaccination. Just keep doing that till we have more data. That's all. I think just protect yourself and others in the time and just have patience. You know, I think in a few months we will have more data. So please stay tuned for that. All right. I think with that, I'll wrap up. Thank you, my panel members here, like, you know, for a wonderful day here, like in the morning, like, you know, all of you guys have been awesome. So I won't take much of your time. And Dawn, please take it away from here.
Yeah, so I just have a couple things to conclude with. Every participant will be getting an email with an evaluation. We've had a lot of questions about whether or not the program is recorded. And yes, the program is recorded. It will be available by the same link that you received to view it live stream. And the email that will have the evaluation, which please fill it out, take a few minutes. It won't be very long. We appreciate the feedback. It will also have handouts for the conference and available. And for those folks who might have had issues trying to visit exhibitors, we will also have an exhibit email go out, and it will have the links of all the companies, Biogen, Novartis, and Genentech, who joined us today. And so you can visit them even after visit their websites even after the program is done. And then I just wanted to do a final thank you for, like Vijay said, the speakers for spending their Saturday talking to all the participants. The feedback we've gotten so far has been really positive, and people have really enjoyed it. So we appreciate your time. For you folks who are viewing it on a Saturday and wanting to get more information about MS, we appreciate it and hope that you found the program very useful. And then I just wanted to also thank our the partners of this program, which is the Portland VA Healthcare System, and a lot of our faculty have appointments at both OHSU and the VA. And so we know there's a lot of veterans that also attended today. And so thank you for joining us. And then lastly, again, I just want to thank our virtual exhibitors, Biogen, Genentech, and Novartis. And their information will be available in the evaluation email that you'll receive. So if you have any questions, just let me know. But anyway, I hope everyone has a wonderful weekend, and thanks again for joining us.
Thank you, Dawn, and thank you, everyone. And thanks for watching. Bye.